Dr. Dilip Sarda, I will request you to remove your virtual background as well.
Archana, we can't hear you, huh?
That's what I'm trying to do an audio check, sir. Am I audible?
No.
I'm not
आता बोल.
audible.
नाही, फार कमी येतोय तुझा आवाज.
I just put on the headphone and see. That's what I'm doing an audio check.
आपल्या बाकीचे मेंबर्स बघा ना, जे नाही आले त्यांना फोन करा. नाही, कोण आहेत ते बघा इकडे.
Hello.
Now
Sir,
you are.
how's the voice quality now?
Yes, now it is good.
Okay.
हे डॉक्टर राहुल पंडित ना फोन करतात, ते उचलत नाहीयेत. जरा बघ ते काय प्रॉब्लेम आहे.
मी करते. I'll call you.
राहुल जॉइन होतोय. डॉक्टर उत्तुरे 2 मिनिटं जॉइन होते. 2 मिनिटं जॉइन होते तो.
ओके.
त्याची ना ते तो ही इज आय थिंक डॉफिंग अँड डॉनिंग, तो जस्ट बाहेर पडतोय मला असं.
नाही, ही इज अ
2 मिनिटं जॉइन होतोय. डॉक्टर बकुलेश मेहता, हाउ आर यू?
तुम्ही ना
क्लोज करना है कैसे? नीचे चैट रूम है, अंदर पार्टिसिपेंट है और रिकॉर्डिंग सब चैट कहाँ है? यहाँ नीचे से ये चैट रूम है. हाँ ठीक.
निसार सर, आपका जरा म्यूट पे रख देना. हाँ,
सूर्य साहब नमस्कार. गुड आफ्टरनून.
नमस्कार. नमस्कार. I think CM Saab's office has logged in. लाणे सर नमस्कार.
नमस्कार सर. हाँ सर. हाँ.
नमस्कार.
We will be starting within 1 or 2 minutes. I think CM साहेबांचा ऑफिस आणि मिनिस्टर साहेबांच्या ऑफिस have already logged in.
लाणे सर नमस्कार.
हाँ मकरन नमस्कार. नमस्कार मकरन.
नमस्कार.
शशांक नमस्कार. राहुल नमस्कार.
लाणे सर नमस्कार.
नमस्कार राहुल बोलतो.
नमस्कार नमस्कार नमस्कार.
सर नमस्कार.
अजित नमस्कार. सचिन नमस्कार.
सर नमस्कार.
नमस्ते लाने सर.
सारडा साहेब नमस्कार.
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 सर नमस्कार.
नमस्कार
Good afternoon,
नमस्कार. अर्चना मॅडम नमस्कार.
नमस्कार सर. गुड आफ्टरनून सर.
गुड आफ्टरनून. गुड आफ्टरनून.
I think मंत्री महोदय 1-2 मिनिटात जॉईन करता आहेत. I think we'll keep a little silence because we are already on YouTube live.
Okay.
त्यांना फोन
मीटिंग आता उद्धव ठाकरे साहेब येणार आहे, त्यांचं जरा झालं की येणार आहे.
ओक सर प्लीज म्यूट करा जरा.
देशमुख सर एका मिनिटामध्ये जॉईन होत आहेत.
हो सर, वी आर जस्ट वेटिंग फॉर देम बोथ टू जॉईन. मग आपण चालू करूया. थोडा सीएम साहेबांना 5-10 मिनिटं उशिरा होईल, ते दुसऱ्या मीटिंग मध्ये आहेत. तर देशमुख साहेब आल्याबरोबर आपण चालू करूया सर. मंत्री महोदय आल्याबरोबर आपण चालू करूया. ते ही सेड गो अहेड विथ द प्रोग्राम, ही विल जॉईन.
साहेब जॉईन होत आहेत. Utture sir, honorable minister sir has joined.
हा नमस्कार सर. सर
नमस्कार.
सर सीएम साहेब थोडे 5 मिनिटं बोलले, ते मीटिंग मध्ये आहेत, ते आपल्याला नंतर जॉईन करतील, बट ही सेड यू कॅन गो अहेड विथ द प्रोग्राम. तर विथ युअर
Yes, you please go ahead.
Okay, sir. Then we'll start the program. Dr. Pate, madam, we can start
Yes,
the
sir.
program.
Thank you so much, sir. A very good afternoon to everyone. I, Dr. Archana Pate, Executive Member, Maharashtra Medical Council, welcome everyone on behalf of MMC President Dr. Shivkumar Utture sir and all honorable members of MMC to this COVID summit. It's more than a year since our medical fraternity is serving tirelessly in this COVID pandemic, but as we all know, the end is nowhere near. With fungal infections on the rise and an anticipation of third wave, which is expected to affect pediatric age group more, it is imperative that we revisit different aspects of COVID with all available armamentarium and prepare ourselves for the future problems to come. With this background, Maharashtra Medical Council has organized this COVID summit. We are very honored and blessed with the gracious presence of Honorable Chief Minister of Maharashtra State and Honorable Minister of Medical Education and Cultural Affairs for the inaugural session of this very important summit. Everyone is requested to kindly maintain silence and put their mobiles on silent mode. Without wasting much time, I herewith invite our MMC President, Dr. Shivkumar Utture sir, to give his welcome address. Sir, over to you.
नमस्कार. शिखर परिषदेसाठी उपस्थित सन्माननीय मुख्यमंत्री साहेब, वैद्यकीय शिक्षण मंत्री साहेब, माझे सहकारी टास्क फोर्सचे सदस्य, फॅकल्टी मेंबर्स अँड डॉक्टर्स, आपण सर्वांचे मनापासून स्वागत करताना अतीव आनंद होत आहे. आमचे आमंत्रण स्वीकारण्यासाठी तथा आपल्या व्यस्त वेळापत्रकातून मौल्यवान वेळ दिल्याबद्दल आम्ही खरोखर ऋणी आहोत. सध्या देशात कोरोनाच्या दुसऱ्या लाटेने हाहाकार माजला आहे. त्या लाटेचा सर्वाधिक फटका महाराष्ट्राला बसला होता, परंतु आता राज्यात मोठ्या प्रमाणात रुग्णसंख्येत घट होताना दिसत आहे. कोरोनाच्या दुसऱ्या लाटेदरम्यान सर्वोत्तम कामगिरी करणारे महाराष्ट्र राज्य व महाराष्ट्राचे मुख्यमंत्री साहेब म्हणून मिळालेला बहुमान आहे. तसेच आपले जे मेडिकल कॉलेजेस आहेत ते टर्शरी केअर म्हणून काम करत आहेत आणि सायलेंटली त्या मेडिकल कॉलेजमध्ये बराच बदल आलेला आहे, जेणेकरून बेड स्ट्रेंथ वाढलेली आहे, आयसीयू बेड्स वाढलेले आहेत, ऑक्सिजन बेड्स वाढलेले आहेत. आणि हे सगळं पॉसिबल आहे आपल्या मंत्री महोदयाच्या सांगण्यावरनं, आणि ह्याच्यासाठी मी त्यांचे फार आभार मानतो. Respected CM sir, you have been leading from the forefront in this battle against COVID. Right from day one, you have formed the task force, which consists of the medical practitioners, the clinical practitioners. And I think taking regular input from them has definitely helped us to control this dreaded disease in the state of Maharashtra. And I think Maharashtra is one of the few states which has involved the medical practitioners actively while formulating all the protocols. Right from the beginning, your test, trace, and treat. The maximum testing has been done in Maharashtra. Because of it, though we had the maximum number of cases, we have definitely got a control on that. Your latest call of Maza Doctor and your talks to family physicians and pediatricians has motivated the Maharashtra Medical Council to hold this summit. Because we have found that especially on, say, WhatsApp group or on Facebook and whatever, there are a lot of unwarranted and wrong messages which are going as far as management of COVID is concerned. Plus the treatment of COVID, as we have seen, changes from day to day, because we are also, this is a new disease and we are also learning about this disease. And the inputs from our task force members has definitely helped all members all over Maharashtra to definitely treat these patients in a better way. Just to give you a little bit of background of Maharashtra Medical Council, sir, we are the first council in all India to go fully digital. Today we are paperless as far as the council is concerned. We have got a state-of-art website which is very interactive. We are the council which have launched the first MMC app, which has definitely helped all our members, all not only in Maharashtra, but even when they go out of India, they can log on to the app easily from their smartphones. We are the first council to get the ISO certification for documentation. Not only that, sir, we are the first council to have a platform for easy dissemination of knowledge by starting our own online dedicated CME platform. We were the first council to grant legal permission to all our members to do telemedicine, that is by telephonic medicine, even before the National Medical Commission gave us the permission. Another thing, sir, the Maharashtra Medical Office has never been shut even for one day right from day one of this pandemic. And the reason behind that was that was the era when we had to give provisional certificates and permanent certificates to the students. And during this period, we have granted 8,500 provisional certificates and 12,500 permanent certificates. And this has helped to augment the medical workers force in the state of Maharashtra. So before ending, I would like to put on record my sincere thanks for helping me and helping the council to hold its summit, to our very own Dr. Lahane sir, Madam Taide Madam, Dr. Taide Madam, and of course, the convener who has taken a lot of work she has done, Dr. Archana Pate sir. Thank you very much. And over to you, Dr. Pate Madam.
Thank you so much, sir, for your kind words of encouragement. And definitely you have been very instrumental in organizing this summit. It is an honor to have with us today our esteemed Minister of Medical Education and Cultural Affairs. I request, sir, to please address our medical fraternity and express his views. Over to you, sir.
Honorable Minister साहेब जरा अनम्यूट करायला लागेल.
सर रिजॉईन होत आहेत, एका मिनिटात रिजॉईन.
नाने साहेब,
हा सर, वेलकम सर. सर जय महाराष्ट्र सर, वेलकम. पाटे मॅडम
Sir, good
मुख्यमंत्री महोदय
afternoon,
आलेले
sir.
आहेत.
Sir, good afternoon, sir.
नमस्कार नमस्कार.
गुड आफ्टरनून सर, जय महाराष्ट्र.
जय महाराष्ट्र. जय
जय महाराज.
नमस्कार डॉक्टर उत्तुरे, जय महाराष्ट्र सर.
जय महाराष्ट्र.
तर फक्त मी आधीच तुमच्या सगळ्यांची परवानगी मागून ठेवतो की माझं बोलून झालं की मला निघण्याची फक्त अनुमती द्या.
शुअर
ठीक
सर.
आहे. हो
हा,
सर.
नाहीतर काय होतं, मला पण मी कार्यक्रम बघतो, मला पण नवीन नवीन काही काही गोष्टी कळतात, परंतु आज थोडी जरा वेळेची आहे.
काहीच हरकत नाही सर.
हा, सुरू
Very
पाटे
kind of
मॅडम
you
बोला,
to
सुरू
join,
करा.
sir. Sir, should I be waiting for Sir Minister sir to join or should I continue, sir?
नाही, आय थिंक सरांना लवकर जायचं आहे. तर लाणे सर, वी कॅन गो अहेड विथ सीएम साहेबांचा स्पीच.
हो सरांना, हो सरांना विचारून. सर देशमुख सरांचं मध्ये थोडं हे झाले होते, ते जॉईन होणार होते, तर आपण अगोदर बोलणार असाल तर आपण बोलून घ्या सर, मुख्यमंत्री महोदय.
एकदा विचारा त्यांना फोन करून पाहिजे.
एक मिनिट. सीएम सर जॉईन झालेत रे. हा मग
काय करू? लाने साहेब, एक काम करा, आपण एक दोन मिनिटं जरा एक थोडीशी मला कल्पना आहे, कोणीतरी थोडी प्रस्तावना करा.
हा चालेल. पाटे मॅडम प्रस्तावना करा.
Sir, basically, thank you so much, sir, for joining. Basically, it's more than a year, म्हणजे 1 वर्षापेक्षा जास्त आपण हे कोविडशी लढत आहोत, पण कोविड संपेल असं काही आपल्याला सध्या तरी दूरच्या भविष्यात वाटत नाही.
पाटे मॅडम, यू आर म्यूट.
हा बोला.
सर, थँक यू सो मच फॉर जॉईनिंग सर. सर, 1 वर्षापेक्षा जास्त आपले डॉक्टर्स कोविडशी लढत देत आहेत, पण कोविड कुठे काय एवढाच संपेल असं वाटत नाही आणि कॉम्प्लिकेशन्स पण आहेत. फंगल इन्फेक्शन्स आर ऑन द राईज आणि त्याच्याबरोबर आता थर्ड वेव्ह अँटिसिपेशन आहे, जिथे पीडियाट्रिक पॉप्युलेशन जास्त इन्व्हॉल्व्ह व्हायची शक्यता आहे आणि त्यामुळेच आम्ही हे कोविड समिट घेण्याचा एक निर्णय घेतला की जिथे आम्ही आमच्या डॉक्टर्सना कुठेतरी एक ऑथेंटिक मार्गदर्शन करू शकू आणि थर्ड वेव्ह साठी प्रिपेअर कसं करायचं किंवा जे फंगल इन्फेक्शन ऑन द राईज आहे त्याच्यासाठी भरपूर व्हॉट्सअप मेसेजेस किंवा लॉट्स ऑफ रॉंग इन्फॉर्मेशन सोशल मीडियावर येते, तर त्यांना ऑथेंटिक मार्गदर्शन कसं करायचं. सो त्याच्यासाठी हे कोविड समिट अंडर द गायडन्स ऑफ प्रेसिडेंट डॉक्टर शिवकुमार उत्तुरे आम्ही हे ऑर्गनाईज केलेली आहे सर.
ठीक आहे, मग मी 2 मिनिटं बोलू.
सर, इट वुड बी
आपण बोलावा सर, आपण बोलावं. हो सर.
मग मी मंत्री महोदयांना नंतर सांगा, त्यानंतर फोन करून क्षमा मागून त्यांची. बरं ठीक आहे. एक खरोखर चांगला कार्यक्रम तुम्ही करतात आणि माझ्या सगळ्यांना शुभेच्छा आहेत. सगळ्यांना पहिलं म्हणजे धन्यवाद देतो. आता किती डॉक्टर्स या कार्यक्रमाच्या निमित्ताने आपल्याला जॉईन झाले असतील, सगळेच्या सगळे काय मला स्क्रीनवरती दिसत नाहीयेत, पण एक थोडा वेगळा प्रयोग म्हणण्यापेक्षा वेगळा मार्ग आपण निवडण्याचा प्रयत्न करतो आहोत. गेलं वर्षभर आपण लढतो आहोत. ही लढाई कधी संपेल, केव्हा संपेल याची वाट बघतो आहोत, पण तशी काय अजून ती संपेल असं वाटत नाहीये. मला खास करून धन्यवाद तुम्हाला सगळ्यांना एवढ्यासाठी द्यायचे की गेलं वर्ष आणि हे वर्ष याच्यामध्ये एक काही फरक नक्की दिसत आहेत, जे मी यापूर्वी सुद्धा बोललेलो आहे. गेल्या वर्षी कोविडची दहशत प्रचंड होती आणि ती डॉक्टरांमध्ये सुद्धा होती. अनेकदा आम्ही सांगत होतो, आवाहन करत होतो की आपले जे जनरल प्रॅक्टिशनर्स आहेत, इतर डॉक्टर्स आहेत, त्यांनी सुद्धा आपापली क्लिनिक उघडावी की जेणेकरून आपल्याला या साथीचा मुकाबला तिथल्या तिथे करता येणं शक्य आहे. पण दहशत एवढी प्रचंड होती आणि आज जसं आपल्याला एक लसीचा तुटवडा जाणवतो आहे, तसं त्यावेळेला बेसिक गोष्टी म्हणजे आपल्याकडे सारे मास्क नव्हते, N95 नव्हते, पीपी किट नव्हते, पहिल्याच्या ह्याच्यामध्ये हँड सॅनिटायझर नव्हते. तर ह्या ह्याच्यामध्ये एक भीती किंवा दहशत असणं हे साहजिकच आहे. ती परिस्थिती आणि आताची परिस्थिती पाहिली तर आता बरेचसे डॉक्टर किंवा जवळपास सगळे डॉक्टर्स यांनी आपापले दवाखाने उघडलेले आहेत, क्लिनिक उघडलेली आहेत, नर्सिंग होम उघडलेली आहेत आणि ट्रीटमेंट सुरू केलेली आहे. हे खूप एक चांगलं महत्वाचं लक्षण किंवा महत्वाचं काम या वेळेला मला दिसतंय. आता हे दिसत असल्यानंतर जो मी एक कन्सेप्ट आणलेला आहे, संकल्पना आणलेली की माझा डॉक्टर, म्हणजे आपल्याला सर्वांना कल्पना आहे की प्रत्येक, मी ज्याला फॅमिली डॉक्टर आपण म्हणतो, फॅमिली डॉक्टर, मग तो डेंटिस्ट जरी असला तरी कदाचित अख्खं कुटुंब एका डेंटिस्टकडेच जातं. जनरल फिजिशियन म्हटल्यानंतर अख्खी फॅमिली त्याच्याचकडे जातं. पेडिट्रिशियन म्हटल्यानंतर मुलं त्याच आपल्या बालरोग तज्ञांकडे आपण कुटुंबीय घेऊन जात असतो आणि त्यांचा सल्ला, त्यांचं औषध हे आपल्याला गुणकारी असतं आणि ते आपल्याला गुण देत असतं. आता जे मला दिसते ते असं आहे की सगळेजण कंबर कसून मैदानात उतरलेले आहेत. गेल्या वेळीची लाट आणि यावेळीची लाट, म्हणजे मी कालच जेव्हा आढावा घेतला, मला आता तुमच्यासमोर यायला थोडासा उशीर झाला कारण बाजूच्या खोलीत माझी बैठक चालू होती. एकूण जर का आकडेवारी पाहिली तर गेल्या वेळेला सप्टेंबरमध्ये आपल्याकडे पीक होतं ह्या लाटेचं आणि ते पीक खालून वर गेलं होतं. आता यावेळेला आपण पुन्हा त्या पीकच्या जवळपास आलेलो आहोत, पण आत्ताचा फरक असा आहे की यावेळेला वरून खाली आपण आलेलो आहोत. आपण त्याच्या काही पटीत वर गेलो होतो. हे गेल्या वेळेचं पीक असेल तर गेल्या वेळेच्या पीकपेक्षा आता आपण काही पटीत वर गेलो आणि आता करत 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 त्याच्यावरती आलेलो आहोत. आणि असं झाल्यानंतर गेल्या वेळेची जी एक सर्वोच्च रुग्णसंख्या होती ती आपल्या काही सणावारी नंतर आली होती. आत्ताची जी रुग्णवाढ आहे ती सणवार सुरू होण्याच्या आधीची आहे. लॉकडाऊन आपल्याला वाढवायचा नाही वाढवायचा हा निर्णय आज घ्यावा लागणार आहे. मात्र गेल्या एप्रिल पासून पुन्हा जो आपण लॉकडाऊन सदृश्य किंवा लॉकडाऊनच केलेला आहे तो आता पुन्हा अनलॉक कधी करणार, आम्हाला थोडंसं मोकळा श्वास घ्यायला कधी देणार, हे आता विचारणा व्हायला लागले आणि ते साहजिकच आहे. कोणालाही बंधनामध्ये अडकून राहणं हे आवडणारं असतं असं नाहीच, मलाही बंधने टाकायला आवडत नाहीच. पण जो समोर धोका दिसतोय तो मात्र मोठा आहे आणि हा धोका जो आहे हा धोका गेल्या वेळेचा तुम्हाला ऐकू येते कारण तुम्ही स्क्रीनवर सगळे नाहीसे झालेत माझ्या. लहाने साहेब ऐकू येते?
हो सर, ऐकू येते सर, ऐकू येते सर,
सगळेच नाहीसे झालेत.
ऐकू येते सर, मला ऐकू येते तुमचा आवाज. ऐकू येतं सर, आवाज ऐकू येत.
बरं ठीक आहे. आता आले तुम्ही. तर गेल्या वेळेत आणि आता आणखीन एक फरक पडला. मी थोडस डॉक्टरांशी बोलतोय, जर माझी वैद्यकीय माहिती चुकीची असेल तर आपण करेक्ट करा, कारण आपलं ज्ञान या क्षेत्रातलं मोठं आहे. मी तुमच्या सगळ्यांकडनं ऐकत मी बोलण्याचा आणि माझं निर्णय घेण्याचा प्रयत्न करत असतो. आणखीन एक मोठा फरक जो झालेला आहे तो व्हेरियंट मध्ये झालेला आहे. गेल्या वेळेचा व्हायरस आणि आत्ताचा व्हायरस ह्याच्यामध्ये फरक झालेला आहे. आत्ताचा जो व्हायरस आहे हा व्हायरस अधिक झपाट्याने पसरतोय. म्हणजे जसं युके व्हायरस होता त्याच्या बरोबरीने किंवा त्याच्या तुलनेत थोडासा अधिक झपाट्याने पसरतोय आणि पसरताना झपाट्याने पसरतोय. मात्र त्यांनी कोणाला ग्रासलं एकदा की त्याला बरा व्हायला थोडा उशीर लागतोय. म्हणजे पटकन तो बाधित होतोय, संक्रमित होतोय, पण त्यातनं कोरोनातून बाहेर पडायला ज्याला लॉंग कोविड म्हणतोय, लॉंग कोविडचे पेशंट यावेळेला आपल्याकडे जास्त दिसत आहेत. आणि हे कमी की काय म्हणून त्याच्यात आता बऱ्याच झालेल्या पेशंटमध्ये म्युकॉरमायकोसिसचे रुग्ण दिसायला लागलेले आहेत. आता मला तुम्हाला हेच सांगायचंय की पहिला जो रुग्ण येणार तो तुमच्याकडे येणार किंवा तुमच्याकडे येतो, तिथे तुम्हाला कळलं पाहिजे की हा कोविड आहे नॉन कोविड आहे. याच्यासाठी आता काही टेस्ट किट पण बाजारामध्ये उपलब्ध आहेत. किंबहुना जर तुम्हाला संशय आला, कारण असं कोणालाच काही कळू शकत नाही, सर्दी खोकला घसा दुखणं पोट बिघडणे जे आता पावसाळ्यात इतर ज्या काही साथी येणार आहेत त्याच्याशी बरंचसं साधर्म असणारी लक्षणं ही कोविडची आहेत. म्हणजे तुम्हाला सुद्धा प्रश्न पडणार की समोर आलेला पेशंट हा कोविड आहे की नॉन कोविड आहे. जर कोविड असेल, कोविडचा पेशंट असेल तर त्याला तो किती सिम्प्टोमॅटिक आहे, म्हणजे माइल्ड टू मॉडरेट ते सिव्हिअर, त्याला हॉस्पिटलाइज करणं गरजेचं आहे की आपण त्याला घरच्या घरी ट्रीटमेंट देऊ शकतो. तुमची मदत जी मला पाहिजे ती यासाठी पाहिजे की त्याला पटकन ओळखणे आणि जर घरी त्याची ट्रीटमेंट होऊ शकणार असेल तर त्याची घरी ट्रीटमेंट बरोबर मॅनेज करणं हे तुमचं काम आहे. हे मला तुमच्याकडनं अपेक्षित आहे. कारण काही वेळेला कारण नसताना रुग्ण घाबरून हॉस्पिटलमध्ये येतात, पण हॉस्पिटलमध्ये जाण्यासारखी त्यांची गंभीरता नसते किंवा तशी आवश्यकता नसते. मग काय होतं की त्यांना ऍडमिट करून घेतल्यानंतर ज्याला आवश्यकता नसते तो बेड ऑक्युपाय करतो आणि ज्याला खरंच आवश्यकता असते त्याला बेड मिळत नाही. इथे जरा आपला हा थोडासा एक विचित्र प्रकार किंवा विचित्र प्रश्न हा निर्माण होतो. तर त्यावेळेला तुम्ही फार महत्वाची भूमिका पार पाडणार आहात. तुम्ही कोविड नॉन कोविड ओळखून एखाद्याला घरच्या घरी काय ट्रीटमेंट देऊ शकतो ती देणं आणि हॉस्पिटल मध्ये कधी न्यायचं, तो रेड फ्लॅग काय आहे ते तुम्हाला ओळखता आलं पाहिजे. की ते नंतरचे डॉक्टर सांगतीलच, मला वाटतं लहानसे हे तुम्ही सगळेजण सांगाल की लक्षणं ही कोणती, म्हणजे मग पल्स ऑक्सिमीटर आलं, ते 6 मिनिट वॉक आले, हे सगळं मला वाटतं आपल्या ट्रान्सपोर्टचे डॉक्टर असतील ते सांगतील. इतर काही ब्लड टेस्ट असतील तर त्याप्रमाणे बघायला पाहिजे. तर हे ओळखून तुम्हाला त्याला घरी कितपर्यंत ठेवायचा, हॉस्पिटलमध्ये त्वरित कधी हलवायचा. कारण जसं मी सुरुवातीला म्हटलं की काही वेळेला अनावश्यक म्हणजे हॉस्पिटलमध्ये नेण्याची गरज नसताना पेशंट हॉस्पिटलमध्ये जातो आणि काही वेळेला आवश्यकता असताना सुद्धा तो उशिरा येतो आणि उशिरा आल्यामुळे तो दगावतो. ह्या दोन्ही गोष्टी आहेत. म्हणजे धरलं तर चावते, सोडलं तर पलटे, ज्याला आपण म्हणतोय तसं ते थोडंसं आहे. तर हे तुम्ही ओळखता आलं पाहिजे तुम्हाला की हे नेमकं कधी आहे. त्याच्यानंतर अनावश्यक औषधांचा अतिरेकी वापर हा सुद्धा एक मोठा आपल्याला ही एक मोठी डोकेदुखी होते. कारण म्युकॉरचे जे पेशंट येतात त्याच्यामध्ये शरीरातली शुगर वाढली असताना जास्त काळासाठी स्टेरॉइड देणं, इतर काही औषधं देणं हे टाळलं गेलं पाहिजे. म्हणजे रोगापेक्षा इलाज भयंकर ह्याही गोष्टी होता कामा नये. आणि काही जण हे घरच्या घरी अंगावरती काढतात. मला वाटते सर्दी खोकलाच आहे काय, तर कोविड थोडीच असेल. तसं नाही, त्याला वेळेत सांगण्याची गरज आहे तुला कोविड झालेला आहे. एक तर घरी तुला जर शक्य असेल विलगीकरण म्हणजे वेगळ्या खोलीत राहता येणं शक्य असेल तर घरच्या घरी तू माझ्या गाईडलाईन प्रमाणे औषधे घे आणि घरी वेगळा राहा, नाहीतर तू तुझा कोविड हा कुटुंबियांना देऊ शकतो. आणि आणखीन एक महत्वाचा मुद्दा जो आहे की आता हे फंगल इन्फेक्शन जे होतंय, म्युकॉरचं होतंय, तसंच पावसाळा सुरू झाल्यानंतर इतर जे मायक्रोब्स आहेत म्हणजे इतर बॅक्टेरिया येणार, इतर व्हायरस येणार, ह्याच्यापासून सुद्धा उपचार करताना काय सावधानता बाळगायला पाहिजे हे तुम्ही लक्षात घेऊन तुम्हाला ती उपचार पद्धती ही अवलंबावी लागणार आहे. म्हणजे काय औषध दिले त्याचं पहिल्यांदा आतापर्यंतचा जो काय अनुभव आहे त्याच्यात आपण म्हणतो की ज्याला सहव्याधी आहे, कोमॉर्बिडिटी आहे, त्याच्यावरती या विषाणूचा जास्त घातक दुष्परिणाम होतो. मग त्याची कोमॉर्बिडिटी लक्षात घेऊन या कोविडसाठी आता काही औषधं आपल्याकडे येत आहेत, काही येऊ घातलेत, काही आलेली आहेत, काही हातामध्ये आहेत, पण त्याचे साईड इफेक्ट कशावरती होतील, किडनी ज्याची बरोबर नसेल त्याला कोणतं औषध देऊ नये, कार्डियक प्रॉब्लेम कोणाला असेल, डायबिटीस कोणाला असेल, ओबेसिटी कोणाला असेल, तर त्याच्याप्रमाणे आपण काय औषध दिलं तर त्याच्यावरती काय दुष्परिणाम होईल, मग तो अधिक गंभीर होईल का, स्टेरॉइड दिल्यानंतर काय होईल, कारण स्टेरॉइड जास्त काळ दिल्यानंतर इम्युनिटी लेवल कमी येते, मग आणखीन काय होईल का. तर या सगळ्या गोष्टींचा विचार करून एक पहिली जी फळी आहे, पहिलं सैन्य, माझं मत तर असं आहे की कोविडचा पेशंट वेळेत ओळखला पाहिजे, त्याच्यापासून त्याचं कुटुंब वाचवलं पाहिजे, त्याला तर वाचवलंच पाहिजे, पण प्रसार हा त्याच्या कुटुंबियांना होता कामा नये. कारण अनेकदा मी तुम्हाला सांगितलं की आता जी तिसऱ्या लाटेची शक्यता आहे ती लहान मुलांमध्ये येईल का, येईल न येईल हा एक अंदाज आहे. पण लहान मुलांमध्ये कोणाच्या मार्फत येईल, जसं पहिल्या लाटेत आपण सांगत होतो की मी सुरक्षित तर माझं कुटुंब सुरक्षित. साहजिकच आहे, पहिल्या लाटेच्या वेळेला ज्येष्ठ नागरिकांना याचा धोका जास्त होता कोविड बाधितांपासून. तसंच जर आता वयाचं अनुमान लावलं तर कोविड बाधित जर कुटुंबातलं एक कोणतरी असेल तर त्याच्यापासून मुलांना हा कोविड होण्याची जास्त शक्यता आहे. म्हणजे पहिल्यांदा आपल्याला कोविड होऊ न देणं, आपण कोविड पासून 2 हात लांब राहणं, हे सगळ्यांनी अंगीकारलं पाहिजे. तर ते सुद्धा एक तुम्हाला सगळ्यांना सांगावं लागेल की ज्याला कोविड झाला असेल त्याला घरी जर जागा नसेल तर त्यांनी कोविड केअर सेंटरमध्ये जाणं हे त्याच्या दृष्टीने आणि त्याच्या कुटुंबियाच्या दृष्टीने फार गरजेचं आहे. आणि त्याचबरोबरीने औषधाचा अनाठायी आणि अतिरेकी वापर हा टाळायलाच पाहिजे, टाळला गेलाच पाहिजे. कृपा करून घरच्या घरी, जसं आता रेमडेसिवीर तर ते यादीतनं बाहेरच काढलेलं आहे. मधल्या काळामध्ये रेमडेसिवीर पण काही ठिकाणी घरी किंवा कुठल्या क्लिनिकमध्ये वगैरे असे दिले जात होते. तर तो एक भाग. म्युकॉरमायकोसिसच्या बद्दल कशामुळे ते डॉक्टर भूमकर असतील तर ते डॉक्टर भूमकर साहेब आपण सांगालच, पण ट्रीटमेंट देताना काय आपण खबरदारी घ्यायला पाहिजे की जेणेकरून आपण म्युकॉरचे पेशंट किंवा म्युकॉरचा हा जो रोग आहे तो वेळेत आवरू शकू. तर अशा काही बऱ्याचशा काही गोष्टी आहेत. मला असं वाटतं तुम्ही सगळेजण सुज्ञ आहात, तुम्ही सगळेजण आता मैदानात उतरलेला आहात आणि म्हणून मी तुम्हाला सगळ्यांना जनतेच्या वतीने माझा डॉक्टर, माझे पण ज्याला म्हणतो ना त्याच्यावरती जास्त विश्वास असतो. म्हणजे तज्ञांचा जरी सल्ला घेतला तरी तो तुमच्याकडेच येतो की मी अमुक अमुक स्पेशलिस्ट कडे गेलो होतो, त्यांनी मला हे औषध घ्यायला सांगितलं, घेऊ की नको. तर हा तुमचा सल्ला जो आहे तो फार लाख मोलाचा आहे, लाख मोलाचा आहे. आणि तो लाख मोलाचा सल्ला देण्यासाठी तुम्ही समर्थ आहात. तुम्हाला कधी काही कोणतीही शंका, कोणतेही प्रश्न या कोविडच्या निमित्ताने असतील तर मला असं वाटतं त्याच्यासाठी लहाने साहेब आपण एखादं काहीतरी प्लॅटफॉर्म किंवा काही ह्या गोष्टी तयार केलेल्या असतीलच. अजिबात प्रश्न विचारायला संकोचू नका. अजिबात कोणताही प्रश्न तुम्हाला वाटला तरी त्याच्याकडे दुर्लक्ष करू नका. कोविडचा पेशंट वेळेमध्ये ओळखा, त्याला घरी ट्रीटमेंट देताना आवश्यकतेनुसारच तेवढीच औषधं द्या, त्याच प्रमाणात औषध द्या. रेड फ्लॅग कोणता आहे ते ओळखा, त्याला हॉस्पिटलमध्ये कधी न्यावं लागणार आहे त्यावेळेला तत्काळ तो हॉस्पिटलमध्ये नेला गेला पाहिजे. आणि आणखीन एक महत्वाची गोष्ट, त्याचाही डेटा मला असं वाटतं असणं गरजेचं आहे. तो म्हणजे कोविड पॉझिटिव्ह पेशंट जरी तुमच्याकडे आला किंवा आपल्या कुठल्या कोविड केअर सेंटरमध्ये गेला तर त्यांनी कोणतं वॅक्सिन, किती डोस घेतले होते आणि कधी घेतलं होतं, ह्याचा एक डेटा आपल्याला पाहिजे. कारण वॅक्सिन दिल्यानंतर त्याचा खरंच त्याची एफिकसी काय आहे ह्याची नोंद ही आपल्याला करणं गरजेचं आहे. हे सगळं मी तुम्हाला का सांगतोय, पहिल्या दिवसापासून आपण एक सुद्धा केस ही लपवलेली नाही. ती एवढ्यासाठी की 100 वर्षापूर्वी आपल्याकडे स्पॅनिश फ्लू ही एक साथ जगभर आली होती. त्याचे फारसे काही डिटेल आपल्याकडे नाहीयेत, पण फोटो जे आहेत ते हेच आहेत. मास्क वापरून म्हणजे रुमाल बिमाल बांधून लोक फिरतानाचे फोटो आहेत. अजूनही 100 वर्षानंतर आपल्या हातामध्ये एक महत्वाची ढाल हीच आहे. पण आणखीन 100 वर्षानंतर पुन्हा साथ अशी येऊ नये. पण जर का दुर्दैवाने आली तर ही साथ महाराष्ट्रामध्ये कुठपर्यंत गेली होती, किती प्रमाणात गेली होती, महाराष्ट्राने त्या वेळेला काय खबरदारी घेतली होती, काय डेटा आपल्याकडे उपलब्ध आहे, कोणती लस, कोणत्या प्लॅटफॉर्मची लस तिकडे आपल्याला प्रभावी ठरली होती, तिला किती या म्युटेशन किती झाले होते, किती म्युटेशननी काय दाद दिली होती, ह्याचा सगळा एक डेटा हा आता तर या लाटेतून बाहेर पडायला पाहिजेच, हा रोग थोपवला पाहिजेच. पण 100 वर्षानंतर सुद्धा जर का गरज लागली तर आत्ताचे आपले तुमच्या सगळ्यांचे प्रयत्न हे तेव्हाही पटकन उपलब्ध असले पाहिजे की काय काय केलं गेलं होतं, काय केलं. म्हणजे आता काही औषधं आपण वापरतो आहोत, प्रयोग करतो आहोत, काही प्रभावी ठरतायत, काही ठरत नाहीत, ती डिस्कंटिन्यू करतोय. ह्या अशा सगळ्या गोष्टी ह्याची नोंद पाहिजे. आणि म्हणून आपल्याकडे येणारा पेशंट हा वॅक्सिनेटेड आहे का, कोणतं वॅक्सिन त्यांनी घेतलेलं आहे, किती डोस घेतलेले आहेत, किती दिवस झालेले आहेत, आणि जर शक्य असेल आणि तो लवकर आला असेल तर अँटीबॉडी पण त्याच्यात आहे का. म्हणजे अँटीबॉडी वॅक्सिन दिल्यानंतर झाली होती आणि तरी त्याला वॅक्सिन झाला, मग तो माइल्ड झाला का मध्यम झाला का गंभीर झाला, हे मला असं वाटतं आपल्याकडे त्याची नोंद असणं हे गरजेचं आहे. असो, मला जेवढं कळतं तेवढं बोलण्याचा प्रयत्न मी करत असतो. हे सगळं आपल्याकडनंच थोडंसं ज्ञानाचे जे काही थोडेफार मला मिळालेले सल्ले आहेत त्यातनं मी बोलतो आहे. असं कृपा करून समजू नका की मी आपल्याला काहीतरी शिकवतोय, पण मला वाटतं की काही ज्या गोष्टी आता आवश्यक आहेत त्या आपल्याला करणं गरजेचं आहे. आणि म्हणून आपण सगळेजण मैदानात उतरल्याबद्दल तुम्हाला सगळ्यांना मी धन्यवाद देतो. लहाने साहेब, आता पुढे आपलं कार्यक्रम चालू ठेवून द्या. या डॉक्टर मंडळींचे काही प्रश्न असतील, काही सूचना असतील तर त्या पण घ्या. आणि एक गोष्ट आणखी सांगतो की गेल्या वेळेला आणि यावेळेला आपल्याला ऑक्सिजन प्रचंड प्रमाणात लागला. आपल्याला राज्यात जेवढा उत्पादन करतो त्याही पेक्षा 500 मेट्रिक टन ऑक्सिजन बाहेरून आणावा लागला. ती वेळ पुन्हा येऊ नये म्हणून माझा प्रयत्न आहे की जी काही छोटी आपली हॉस्पिटल किंवा नर्सिंग होम असतील, इकडे आवश्यकतेनुसार छोटे जर ऑक्सिजन प्लांट लावले आणि प्रत्येक छोटी हॉस्पिटल जर का आपण स्वयंपूर्ण करू शकलो ऑक्सिजनच्या बाबतीत, तर उद्या एक जो काही आपला अंदाज आहे तिसऱ्या लाटेचा, त्या तिसऱ्या लाटेचा मुकाबला करायला आपण सज्ज असो. सर्वांना पुन्हा एकदा मी धन्यवाद देतो, सगळ्यांना शुभेच्छा देतो आणि इथेच थांबतो. जय हिंद, जय महाराष्ट्र.
आदरणीय सर, थँक्यू व्हेरी मच. उत्तरे साहेब किंवा कोणी सरांचे आभार मानून घ्या.
नाही ऐका, आभार वगैरे मानू नका. मला तुमचे आभार मानायला पाहिजे. तुम्ही या लढाईमध्ये काम करताय, मी तुमचे आभार मानतो. माझे आभार वगैरे मानण्याची गरज नाही. फक्त मला निघण्याची आता परवानगी द्या. कामकाज तुम्ही चालू ठेवा.
हा सर,
Sir, can you please announce this? Hello. Sir, can you please announce this summit to be open, sir? Inaugurate, please, Karal, sir.
मी आता या चर्चासत्राचं उद्घाटन झालं असं जाहीर करतो आणि नक्कीच मला खात्री आहे की या चर्चासत्रातून भावी संकट हे आपण थोपवण्यासाठी मार्ग दिसेल आणि आत्ताचं संकट, ज्या संकटात आपण सापडलेलो आहोत त्या संकटातून बाहेर पडण्याचा मार्ग दिसेल अशी अपेक्षा करतो. पुन्हा एकदा सगळ्यांना शुभेच्छा देतो. जय हिंद, जय महाराष्ट्र.
थँक्यू सर. थँक्यू फॉर कमिंग अँड जॉइनिंग. थँक्यू सर.
सर गेले वाटतं सर.
नाही, काय बोलायचंय का?
हो सर, मी डॉक्टर उत्तुरे, प्रेसिडेंट. एवढंच, म्हणजे तुम्ही यायच्या अगोदर माझं स्पीच झालं होतं. सर, ही जी प्रेरणा आम्हाला मिळाली हे समिट घ्यायची, बेसिकली तुमचा जो संभाषण होता पिडियाट्रिशियन्स बरोबर, फॅमिली फिजिशियन्स बरोबर आणि माझा डॉक्टर म्हणून जेव्हा तुम्ही सांगितलं तर त्याच्यानी ही आमची ही संकल्पना होती ही. आणि ह्याच्यामध्ये कसं आहे सर की मीडियामध्ये इतके अनवॉरंटेड आणि अनसबस्टॅन्शिएटेड ट्रीटमेंट्स आणि प्रोटोकॉल्स येत आहेत, म्हणून आम्हाला वाटलं ऑथेंटिक आपली जी MMC ची जी बॉडी आहे, ही जी गव्हर्नमेंटची बॉडी आहे बेसिकली, calling all the task forces online to give their say, that would go, the right message would go to all our members. आणि very fact that sir, more than 21,500 डॉक्टर्स ऑलरेडी ऑफिशियली रजिस्टर झालेले आहेत, जे आपण लाईव्ह फेसबुक आणि युट्यूब वरती पण हे टाकलेलं आहे. व्हेरी फॅक्ट दॅट इज, सो द डॉक्टर कम्युनिटी वॉन्ट टू वर्क विथ द गव्हर्नमेंट टू ब्रिंग दिस कोविड डाऊन ॲज फार एज महाराष्ट्र इज कन्सर्न. आणि थँक्यू व्हेरी मच फॉर कमिंग हिअर अँड फॉर गिव्हिंग अस एन्करेजमेंट सर. पुऱ्या महाराष्ट्राचे डॉक्टर्स आपले आभारी आहेत सर.
आभारी आहे. आणि मला कल्पना आहे की थोडीशी तुम्हाला अडीअडचणीचा सामना करत हे काम करावं लागतंय, मला त्याची कल्पना आहे. पण पहिले हे संकट जे आपण म्हणतो जीवावरचं आहे ते त्याचा मुकाबला करू आणि मग आपल्याला या काही गोष्टी पुढच्या सुकर करायच्या त्या पण करूया. आभारी आहे.
थँक्यू सर.
Thank you so much, sir, for your encouraging words. It is rare to find a leader who understands the problem and leads from the front. I now invite our Vice President of Maharashtra Medical Council, Dr. Vinky Rugwani, to give a vote of thanks. Over to you, Vinky, sir.
Good afternoon, all. I consider it as a great privilege to propose this vote of thanks to all the dignitaries who have made it convenient to attend this COVID summit. Thanks to Honorable Chief Minister, sir, for enlightening us with his unique ideas. I express my sincere thanks to him for gracing this occasion. Your presence, sir, has immensely enhanced its cause and importance. I am sure your motivating speech, inspiring speech has left everyone delighted. I just cannot stop myself from mentioning here the way you handled this tough situation in the state. I take this opportunity to thank you, sir, once again on behalf of each and every person present here. I feel overwhelmed as next on the list for me to express my gratitude is our own Minister of Medical Education, Honorable Amit Ji Deshmukh. Not only today, but each time whenever Maharashtra Medical Council have needed your help, sir, and needed your assistance, you have provided us with a very generously. Your guidance is a motivation for all of us, and with every time. Our biggest thank to you, sir, for turning our request into the gift for us by getting this function inaugurated by Honorable CM, sir. My sincere thanks to you, sir. Ahead in this 2-day program, we all will be listening to the speakers and panelists, all towering personalities who are great visionaries who have done a tremendous job in their field and profession. So thanks to all speakers and panelists of this summit. My heartfelt thanks to the MMC president and all my colleagues, team members for putting up an excellent show. With this, I declare this inauguration function to end here. Thank you. Thank you so much.
Thank you very much, everybody, for having attended this inaugural function. I think we are running late, so we can immediately start the function, and I hand over to Dr. Pate to continue with the actual education program.
Thank you so much, sir. And now we move forward to our scientific sessions. Beginning with the first session, as we all know from our UG days, viruses have always been known to mutate. But has this mutated virus brought any changes in the clinical presentation, complications, and the way we consider treatment? Also, with ongoing clinical trials, we hear about many different drugs being given emergency use authorization for treatment in COVID. So let's begin our first session. Overview of COVID infection, presentation, complications, and treatment. And for this, we have with us our first esteemed speaker, Dr. Rahul Pandit. This session will be chaired by our Honorable Executive Council members, Dr. Ajit Gopchade and Dr. Makarand Vyavare. Dr. Ajit Gopchade, sir, is a pediatrician. He's past Vice President, MMC, Management Council member, MUHS, and member, National Road Safety Transport Ministry, Government of India. Dr. Makarand Vyavare, sir, is professor and head of Department of Forensic Medicine and Toxicology, IGMC, Nagpur. He is teacher for UG and PG students for last 25 years. Sirs, I request you both to kindly take over the proceedings. Over to you, sir.
धन्यवाद डॉक्टर अर्चना पाटे मॅडम. महाराष्ट्र मेडिकल काउन्सिलच्या आयोजित या अतिशय उत्कृष्ट कार्यक्रमाच्या नियोजनाबद्दल मी अध्यक्ष डॉक्टर शिवकुमार उत्तुरे, अर्चना पाटे आणि सर्व सदस्यांचं मी मनापासून अभिनंदन करतो की महाराष्ट्रामधल्या सगळ्या डॉक्टरांचं प्रबोधन करण्याच्या दृष्टीने हा कार्यक्रम निश्चितच यशस्वी होईल. आणि मी आजच्या या कोविड समिट मधील सर्व महाराष्ट्रातील व भारतातील वैद्यकीय क्षेत्रातील सर्व मान्यवरांचं मी हार्दिक स्वागत करतो. आजच्या या विषयाचे प्रमुख वक्ते माननीय डॉक्टर राहुल पंडित हे महाराष्ट्रातील वैद्यकीय क्षेत्रातील गणमान्य व्यक्तिमत्वांपैकी एक आहेत. त्यांच्या व्यक्तिमत्वाचा परिचय महाराष्ट्रातील सर्वसामान्य जनतेपासून अनेक लोकांना या संकट काळामध्ये झालेला आहे. डॉक्टर राहुल पंडित हे फोर्टिस हॉस्पिटलच्या मुंबई या मोठ्या नामांकित रुग्णालयाचे ते इंटेन्सिव्ह केअर युनिटचे ते डायरेक्टर आहेत. ते व्हिजिटिंग कन्सल्टंट म्हणून बाथरूस्ट हॉस्पिटल आणि वागा वागा हॉस्पिटल ऑस्ट्रेलिया या ठिकाणी त्यांनी एक नावाजलेलं व्यक्तिमत्व म्हणून त्यांनी काम केलेलं आहे. सुप्रीम कोर्टाच्या निर्देशानुसार मेंबर ऑफ नॅशनल टास्क फोर्स या दृष्टिकोनातून देखील ते सर्वोत्कृष्ट कामगिरी संपूर्ण देशभरामध्ये आता करत आहेत. महाराष्ट्र शासनाच्या टास्क फोर्स फॉर कोविड-19 याचे पण ते गणमान्य सदस्य आहेत. ही इज अ टीचर फॉर कॉलेज ऑफ इंटेन्सिव्ह केअर मेडिसिन इन ऑस्ट्रेलिया अँड ISCCM फेलोशिप अँड डिप्लोमा कोर्सेस. त्यांनी अनेक मल्टिपल ओरिजिनल पब्लिकेशन्स, बुक चॅप्टर्स, लेक्चर्स आणि सायंटिफिक प्रेझेंटेशन्स वेगवेगळ्या आंतरराष्ट्रीय पातळीवरती केलेले आहेत. त्यांचा स्पेशल इंटरेस्ट क्रिटिकल केअर, इकोकार्डिओग्राफी, अल्ट्रासाउंड, ब्रेन ट्रोमा आणि ऑर्गन डोनेशन या विषयामध्ये डॉक्टर राहुल पंडित सर यांनी विशेष कार्य केलेले आहे. मी परत एकदा राहुल पंडित सरांचं मनापासून आभार व्यक्त करतो आणि धन्यवाद व्यक्त करतो. राहुल पंडित सर, आपण सर्व महाराष्ट्रातील वैद्यकीय जगताला मार्गदर्शन करावे ही आपणास नम्र विनंती. धन्यवाद.
Thank you, Dr. Gopchade, sir. Thank you very much for the kind introduction, and it's really an honor and indeed a pleasure to be here for this summit with all the luminaries in the state. And it cannot be a bigger honor than this to have the Honorable Chief Minister and the Honorable Minister inaugurate a session. So I'm just going to start off with sharing my slides. Are my slides visible for everyone?
Yes.
Yes, yeah.
Thank you. So as Dr. Pate mentioned that we're sort of, it's a bit of a bigger topic to talk about. I have taken the liberty to have a couple of things left out for the subsequent speaker because I was just speaking with Dr. Doshi. A few of the things may actually be relevant to home care and what he's going to talk about. So I've not touched upon a few drugs. But at the outset, I think all of us need to realize that COVID is here to stay. It's going to stay for some time. And the reason why we are doing this summit today is to essentially understand how are we going to move forward and what has been transcribed in the last 15 months that we have been fighting with this pandemic. It is going to be a hybrid hospital model, which is going to probably be the way to go forward. There's going to be no place in any hospital or anywhere in the world currently where you can say there is no COVID. So most hospitals will have to coexist with COVID and other non-COVID work which is going on as well. Let's come up straight to the topic. So if you look at COVID-19 and we start thinking what is the predominant pathophysiology of this, we see these 4 different stages. Now the good fortune is that most patients probably don't go through all the 4 stages, and many of them probably limit themselves to the first 2 stages, and that too in a very milder way. There are some of them who then go across and have the pulmonary phase, dysregulated immune response phase, and the ARDS phase. And if you look at this beautiful diagram, it actually explains to us very, very lucidly what are those phases which sort of contribute towards the clinical symptoms. And if you look at this first slide on the left side, first column on the left side, where you have this flu-like illness, you have constitutional symptoms, you may have a little bit of lymphopenia in your blood. And those are the early signs, early signs of infection, where you actually have the viral phase response. The viral replication is happening, and you start seeing that the viral replication starts to taper down, and it starts to taper down around day 7, day 8, and that's when your pulmonary phase comes in. And pulmonary phase has got obviously 2 different categories again. One is where you probably have a lower respiratory tract infection but don't precipitate with hypoxia, and the other one where you have hypoxemia as evident by a PF ratio of less than 300. Along with that, you also have the tests of chest X-ray or maybe transaminitis or maybe a high CRP, low procalcitonin, which might be coming up. And then there are a few unfortunate ones who, despite treatment, do progress on to become full-blown ARDS, where we have all the cytokine panels go up, and that stage is called as the hyperinflammatory stage or the stage 3. And this is where the mortality is maximum in the stage 3. When we are seeing patients progress onto the stage 3, that's the stage where we actually need to concentrate our most, because if we have to save lives in this pandemic, we need to prevent people from going from stage 2 to stage 3. But once they go to stage 3, we need to ensure that they get the right treatment. And obviously, based on those stages, you start dividing where are we going to look after these patients. So asymptomatic and mild are obviously going to be looked after in corona care centers or at home isolation, as long as the true spirit of home isolation is followed. In moderate cases, we look after them in the wards or in the high dependency unit, but the severe cases are obviously going to be needing intensive care. Coming to the symptomology, a lot of symptoms have probably not changed. In fact, a few symptoms may have been added up in the second wave. And the GI symptoms seem to be the predominant ones which have been added on in the second wave. And in the mild patients, what we normally have is a flu-like symptom, fever, cough, soreness of throat, nasal congestion, malaise, headache. Some of them actually present with GI symptoms like diarrhea, loose motions, and frequency may be quite rapid as well in the few days, in the initial few days. But there is one clear distinction there. They don't have any evidence of shortness of breath or hypoxemia. Then when we look at the mild cases, you actually have some involvement of the lung coming in through the moderate patients. And those are the patients who probably have got pre-existing comorbidity. But in the second wave, we started seeing that even patients who were having only mild disease or who were having only, they were adolescent, they were young, they were between their 30s and 40s, you would see them to actually have progressed on to the moderate cases. And then you probably had no drop in saturation at that stage. But it was the severe patients who obviously caused the biggest problem for us, who progressed on to have severe pneumonia, who had more than less than 90% saturation, a respiratory rate which was starting to go up beyond 30 breaths per minute. And then unfortunately, some of them progressed on to have an ARDS. comorbidities was an important predictor factor in the first wave as well as in the second wave. Those patients who had the comorbidities like hypertension, diabetes, obesity, heart disease, renal failure, they were the ones who had a very, very tough time trying to recover once they went into the severe phase. Now, there's something interesting about ARDS I would like to talk about. We all look at the saturation. We all look at the CT scan scoring, and we've got Dr. Bhavi Jankaria who's going to talk about this later on in the day. But I would just like to allude to 2 points which are clinically relevant for me as a clinician. You look at the scan up here, the image A. You have your PF ratio around 95, which is less than 100. This patient is already in severe ARDS. But look at the scan doesn't look like a severe ARDS. If you look at the total scan, the scoring may come up as a moderate scoring. And that is basically very, very deceptive, because sometimes you may have a clinical radiological dissociation where radiologically you may not be that bad, but clinically you may already be fitting into a severe ARDS category, and vice versa is true as well. Radiologically, you may be actually like somebody who is on the scan on the image B out here. Of course, this person has got a PF ratio below 100 as well, but at times we have seen that the PF ratio is not that bad in these patients. The compliance may not be that poor as well. If you look at the Berlin definition, in the Berlin definition, this was in 2012, we looked at patients with ARDS. We found out that we could actually have a categorization of these patients into mild, moderate, and severe based purely on your PF ratio. Now, why am I harping on the PF ratio a lot? Lot of us are looking at only saturation. Once the patient is hospitalized, it is important to at least have an understanding what the PF ratio is, specifically once they progress into the moderate reach. Mild patients obviously don't need to worry about it, but moderate to severe without ABG, you would not be able to actually categorize these patients. What is important as per the Berlin definition, that you only categorize them when they at least have a PEEP of 5 centimeters of water. That means they should either be on high flow nasal cannula or a non-invasive ventilator to actually try and fit them into a Berlin definition. If there is no PEEP or no presence of CPAP, then it is difficult to actually categorize them into a Berlin definition and say whether it is mild, moderate, or severe. One of the simpler ways of categorizing patients in hospital is to look at the new score. The new score looks at these clinical parameters in which you don't have PF ratio, but you've got age, respiratory rate, saturation, supplemental oxygen requirement, systolic, systolic blood pressure, heart rate, level of consciousness, and temperature. And then you can categorize them based on the score which they have. Anybody who has a score greater than 4, or anybody who has got one category of a score of 3, needs to be monitored very, very closely because they have a potential to worsen. Another very practical thing is to do a 6-minute walk test. For people above 60 years of age, you could reduce the time to 3 minutes. What we are essentially looking at is a drop in saturation from a baseline, and baseline is considered to be normal, which is above 96%. If you have a drop in saturation of 3% from the baseline or drop below 93% at any time, those are the patients who are probably going to require supplemental oxygen, who probably need to be in the hospital, who probably need to be given some supplemental steroids as well based on inducible hypoxemia. So oxygen has been the mainstay of this whole pandemic. And as we heard the Honorable CM say, that we were requiring more than 500 metric tons of oxygen than what Maharashtra state is actually producing. So Maharashtra was using around 1800 metric tons plus of oxygen during the 2 months of the pandemic in the second wave. And that's a lot of oxygen. And that's why it's important that we understand how are we going to use this oxygen as a commodity, which is now being categorized clearly as a drug. We never have talked about it as a drug, but WHO, as well as even our drug list, oxygen is a drug. It should be prescribed properly. There should be some prescription guidelines for that. And what is the prescription guideline? In patients who are sick, it is very clear that you can have a saturation of 93 up to 93%, and you don't need to give them supplemental oxygen. You probably need to keep their saturation below 94, 96%. And if they remain hypoxic, you can start turning them and make them awake prone. This is a very simple thing to do, does not cost any money. And the first thing I think all of us as doctors, we should tell our patient is that if they're calling you up and saying my saturation is low, first thing is don't panic, lie down prone and let's start seeing how your saturation picks up, and simultaneously start working to get them a bed in a hospital or in a COVID care center, depending on what categorization of the patient you've done for this patient. Obviously, some patients may require non-invasive ventilation, some patients may require HFNC. HFNC has come under a lot of criticism because of the oxygen it uses. So it probably typically uses a flow between 40 to 60 liters per minute. And if a patient is on 100% FiO2, the only 21% is going to be derived from air. Rest 80% will have to be given by supplemental oxygen. So that's a large amount of oxygen going for one patient per liter. But look at the way the patient is. The patient has got best amount of stability in terms of compliance with an HFNC. So if you can use HFNC, awake proning becomes easier. But obviously, when you have oxygen shortage, it is criminal to use HFNC. You should not be using HFNC. The flows can be brought down to almost 20 liters per minute by using a non-invasive ventilator. So please go on to non-invasive ventilator. So going to modify some goals of ventilation. What is the modified goal of ventilation? Oxygenate to correct hypoxemia. What is hypoxemia? Around 90% or low saturation in a hospitalized patient who is monitored. Patient who is not monitored, around 92 to 94% is an acceptable saturation. You try and give them enough oxygen to maintain that saturation level and then start turning the oxygen down. Do not have hypoxemia or do not have a saturation which is greater than what is required. Just try and keep it at a bare minimum rate. The other goals of mechanical ventilation are that you try and use it when patient has got a increased work of breathing. And when the increased work of breathing is there, you probably need to supplement them with some form of a mechanical device like a non-invasive ventilator or a mechanical ventilation. It is important that we do not lose the sight that if the patient is hypoxic and despite best of your efforts, he remains in a mechanical way, he remains hypoxic because you've used non-invasive ventilator or you've used HFNC, then do not wait or prolong to intubate them. You need to put them on a mechanical ventilator when it is indicated. A rule of thumb is that if your PF ratio remains below 100, despite best of the efforts with non-invasive techniques, please go ahead and intubate these patients. Because what we are seeing is that a lot of patients are actually not intubated, and we are essentially using a lot of drugs as a substitute for intubation. And in short, we are losing patients because of that. Prone position, I can't overemphasize that. Whenever we intubate the patients, go across and prone the patients. It is the best recruitment maneuver which you can use right now in your patients. And what happens is essentially a simple physiology change. Your dorsal becomes ventral and ventral becomes dorsal. Your FRC improves, your secretion clearance improves, your ventilation perfusion mismatch improves. So do not delay intubation, prone early, follow the basic rules. And when you are using mechanical ventilation, use muscle relaxant and sedation. Just a couple of things about mechanical ventilation. 2 trials were done. One was an ARTSNet trial, which looked at low tidal volumes. The norm is now to ventilate them with low tidal volumes, even though you may have a different phenotypes, which may be reported in the ARDS right now in the COVID-19 era, but try and maintain them to around 6 ml per kilo tidal volume. It has shown a mortality benefit. Similarly, the PROSEVA trial, which looked at a proning trial, has shown a mortality benefit. It pains me that people are not able to prone even in a smaller setup, because proning is something which is so easy to do. It probably requires a little bit of manpower, but it is very easy to do. And if we can awake prone or mechanical ventilator prone, I think it will save a lot of lives of patients. These are proven therapies. Let's go back to our basics rather than exploring therapies which have not been proven. Muscle relaxation for 48 hours initially, again, has clearly shown to improve outcome. So when you are sedating these patients, don't forget to paralyze them for 48 hours and prone them so that their outcome can be better. Something which is so simple to do is what we all intensivists know is a mnemonic called as a fast hug BID. I think everybody, all patients who are in your hospital, whether they are on a ventilator or not, whether they are in the ICU or not, if you can just go through this mnemonic, I think we will be doing all the basic things which are right for the patient. So F for feeding. Make sure that their feeding regime and the diet regime is correct. Always try and see if they require any pain relief. Sedation would be more pertinent to patients in ICU. Forget about them. If the patients are not in ICU, you can forget about this S. Thromboprophylaxis, the T stands for thromboprophylaxis. If the D dimer is high, you can start a therapeutic dose of thromboprophylaxis, unfractionated heparin, or make sure that you actually attend to it. Here, head was traditionally head high position, but I've changed it to a head in a prone position. Ulcer prophylaxis, glycemic control is ever so important now with the resurgence of mucormycosis which we are seeing. If the patient is intubated, spontaneous breathing trials, bowels. If the patient does not need indwelling catheters like Foley's, central line, arterial line, peripheral cannula, remove them if they are not needed. And obviously look for agitation, early signs of confusion, sometimes ischiocycosis. If you do all of these fast buck hug BID twice a day for your patients, you would actually be doing a very, very good job anyways. Let's come at some of the therapies, some of the drugs which have shown up. The original trial, which was basically talking about the use of drugs, was the recovery trial. The recovery platform has looked at several drugs now. The best drug which came out up until now has been the steroids. They used dexamethasone in hospitalized patients with COVID-19 and definitely found a mortality benefit. However, steroids are double-edged swords. We need to be aware of when we will use them and when we will not use them. So if you try and step out of the box of the trial and start using steroids beyond that, then you're obviously going to cause some amount of harm. So what is the norm? The norm was low dose steroids. The new dose of steroid use was 6 milligrams per day, which actually equates to around 40 milligrams of methylprednisolone a day. So if you're going to use probably 1 milligram per kilogram per day or 1.5 milligram per kilogram per day should be the maximum dose of methylprednisolone, or 6 milligrams of dexamethasone per day is what you should use. Try and stick to an OD dose or a maximum BD dose of whatever you're using. If the patient has got sepsis and you are trying to deal with COVID as well as sepsis together, you may change it to 50 milligrams of hydrocortisone 4 times a day, which is the surviving sepsis guideline dose, which equates to around 30 to 40 milligrams of oral prednisolone a day. Oral prednisolone should be avoided as far as possible unless you're on a weaning regime. So IV methylprednisolone or IV dexamethasone in 1 milligram per kilogram per day of methylpred or 6 milligram per day of dexamethasone is what we should be using. The other drug which has gone through a lot of rigors of clinical trial has been remdesivir. Unfortunately, in all the trials, it showed that there is no mortality benefit. Then why am I talking about it? Why am I even saying this? So, well, what trials have shown clearly is that it actually saves a day or two of hospitalization, perhaps even up to 3 days of hospitalization. Now, I look at it in a completely tangential way. First, when we had hospitals which were full of patients and patients were not getting beds, it is actually a luxury to have somebody who could be discharged 2 days earlier. So remdesivir, I think, fits the bill there. Secondly, if my patient is going to have one less day in a ICU, one less day on a ventilator, one less day of central line, one less day of arterial line and Foley's catheter, I think I'm saving him from a secondary infection quite a lot. And I would use remdesivir for that cause, but I would use it within the guidelines. What are the guidelines? Guidelines are don't use it beyond 10 days of onset of symptoms, unless, of course, you have a patient who is immunocompromised from before. Then you need to discuss it with one more doctor at least, so that you are actually using it beyond the 5 days, beyond the 10 days. But 99% of the patient, you would be using it within the viral replication phase within the 10 days. 5 days is as good as more than 5 days. So do not go more than 5 days of regime. I think there is no point in giving more than 5 days of drug. Use it as a rule of thumb for patients who require supplemental oxygen. This is a drug which has been shown to basically have its effect in the patients who are moderate to severe, and within 10 days of their illness. So if you try and use it within that timeline, you would actually be having the best use of this drug. The second drugs which have come across for the use of this cytokine storm. I'm not going to go into the details of how cytokine storm happens, but this slide actually depicts the various ways in which the cytokine actually affects our body and various drugs which have been used. So, for example, you have got your IL-6 receptor inhibitors like tocilizumab and sarilizumab here. Then you've got your JAK inhibitors, which actually have got some role in promoting your cytokine, which is the baricitinib and other JAK drugs. And plus you may have your other medications which we have used, like interferons, which is an antiviral medication. We know that interferons have got some antiviral properties. Or you may have some other of your agents where people have used in these group of drugs like serine kinase inhibitors and stuff, which may be helpful in cytokine storm. But let me go to the evidence. Monoclonal antibodies like tocilizumab, itolizumab have basically been now studied by the recovery platform as well. And there were two trials which came out. This was the latest trial from on tocilizumab, which recovery trial said that it actually made a mortality benefit. It made a mortality benefit. And the meta-analysis looking at all the trials which use tocilizumab actually probably concluded that the tocilizumab use was better. But all of them universally came up with a time window in which you could use tocilizumab. So what is the time window? Tocilizumab still remains as an off-label use when all of the below criteria are met. All is important. It's not just one. Presence of severe disease within 24 to 48 hours, significantly raised inflammatory markers, not improving despite use of steroids, no active bacterial, fungal, or tubercular infection, then a single dose of 4 to 6 milligrams up to 400 milligrams in a 60 kilo man person can be used as an infusion over 1 hour. I think if we follow this regime, we probably are going to be in a reasonable way. If we step out of this regime, again, we are exposing the patient to immunosuppression and secondary infection. Convalescent plasma, no role, period. I think we should not be discussing about it. Baricitinib, I think baricitinib was used in combination with remdesivir in patients who did not receive steroids in this trial or steroids were contraindicated. And this is a very good slide we actually have taken up from New England Journal of Medicine, which summarizes the whole trial. It was a double-blind, multi-center randomized control trial having around 1,000 patients, 515 in each arm. Median time to recovery was 1 day better when baricitinib was used with remdesivir, but the median time to recover among patients who required high flow oxygen was significantly different, 10 days versus 18 days. Mortality benefit was just mildly seen there, but I think there is some merit in using this drug in patients in whom you may not want to use steroids, because the evidence for steroid is much stronger than this. Otherwise, the newer drug which is on the block is the pegylated interferon. It's an antiviral medication. Again, there's a phase 2 data. You can look at the numbers, only 85 to 90 patients seen. And there is obviously some improvement seen in this patient. I have not seen the phase 3 data, and I have not got access to the phase 3 data to actually show you. But there is some data which actually shows much more benefit than what I am seeing out here. Other medicines, I'm going to have my colleague, Dr. Doshi, who's going to follow me talk about it. The colchicine, budesonide spray, and the antibody cocktail which has come, because I think that cocktail should be used before the patient gets admitted. It is not something which after the patient gets admitted. So I'm going to leave that to Dr. Doshi to discuss. The other medicines which have been used are 2-deoxy-D-glucose, the DRDO medicine, ulinastatin, thymosin alpha, other JAK inhibitors, infliximab, Sepsivac. None of them have got any evidence to be actually used or talked about. I'm not going to talk about these medicines. These are medicines which have got completely off-label use. And while people may have used them in one-off patients and have had success, they cannot be recommended as any form of therapy or standard of care. Last two slides, I think there is a very, very crucial need to have an oxygen stewardship program in each hospital. We should have oxygen stewards appointed in each hospital, whether it's a small nursing home or a big hospital or multi-specialty hospitals or public hospitals, these stewards should preach and practice rational use of oxygen. We should have oxygen committees appointed within the hospital. There are models which are already existing in Mumbai. Hinduja Hospital has got a very good audit committee. We have a very reasonable audit committee which looks at oxygen use, monitors its use, looks at the supply, projected demands over the next 24 hours, and we already have all of this data in place a day prior. We decide which patient to give oxygen, which patient who does not need oxygen, the oxygen should be turned off. Wastage of oxygen is as criminal as anything else. Your pipes, valves, nuts, bolts, everything should be scrutinized every day. The system should be looked at in such a way that we have minimum usage of oxygen and use appropriate mask or device to deliver oxygen. If somebody can be monitored and treated on a nasal prongs, There is no point in giving them a mask with a non-rebreather and 12 liters of oxygen going through and a saturation of 100%. Remember, every liter of oxygen saved is 1 liter of oxygen produced. Change your targets in monitored and non-monitored areas. Have differential targets. In a monitored area, you can keep the target low. Use awake prone, use NIV instead of HFNO, and oxygen concentrators in smaller hospitals. Thank you very much. I'll be happy to take questions if you have any. I'll stop sharing my slide. Thank you.
Sir, due to restraint of time, you have covered each and everything, sir. Whether there are certain questions, sir, whether to remdesivir is given or not, about CRP protocol, and whether the non-invasive or invasive ventilation is necessary or not. Then about the role of steroid in mucormycosis. Every questions are covered, sir. But because of restraint of time, we are now not taking the any questions, sir. Just I want to say something about your talk, sir. Sir, good afternoon all, sir. Honorable Sri Uddhavji Thackeray, sir, Chief Minister of Maharashtra. Honorable Sri Amitji Thackeray, sir, Minister of Medical Education and Drug Department, Government of Maharashtra. Respected Dr. Lahane, sir, Director Medical Education and Research, Government of Maharashtra. Respected Tade Madam, Director Health Services, Government of Maharashtra, and all respected members of Maharashtra Medical Council and dear delegates. I would like to thank Dr. Rahul Pandit, sir, for giving valuable information about the COVID infection, complication, and its management. Pandit, sir, your talk was precise and very informative. In such a short time, I convey my regards to Pandit, sir, for sparing his valuable time and sharing his views about the COVID with all of us. I am sure that all delegates will be definitely benefited and enlightened. This refreshment of knowledge will definitely help them in patient care in their routine clinical practice. I take this opportunity once again to thank all of you. Over to you, Archana Madam.
Thank you, Rahul Pandit, sir.
Thank you, sir. Thank you.
Thank you very much.
Thank you, Dr. Pandit, for this lucid session. I just had one request to Dr. Pandit, since we are in a paucity of time, if some questions, relevant questions come in the Q&A box, if you could be kind enough to be around for some time and answer those, on the Q&A box. So if the participants want to ask, they can ask in the question and answer box. Everybody, please.
I will type them back, madam. No problem.
Thank you so much, sir. Thank you, Dr. Gopchade and Dr. Vyavahare for chairing this session. We now move on to our next session. As we are very well aware by now, about 80% of COVID patients present with only mild symptoms or they are completely asymptomatic.
Madam, mute झालाय तुमचा.
Madam, you got muted.
Unmute yourself. Yes, sir. So as we are well aware by now, 80% of COVID patients present with mild symptoms or are completely asymptomatic. Majority of these patients opt for home isolation and consult their clinicians either in person or via tele or video consultation. So it is important that we know about the latest in management of home isolation patients and the red flags which should prompt us to consider hospitalization. For this, we have with us our next expert speaker, Dr. Shashank Joshi. To introduce our speaker and to chair this session, I invite our Honorable Council Member, Dr. Nisar Ahmed Sheikh. Dr. Sheikh is consulting family physician practicing since last 40 years, Director, Saideep Healthcare and Research, Ahmednagar, and past Vice President of IMM Maharashtra State. Over to you, Nisar, sir.
Thank you, madam. On behalf of the Maharashtra Medical Council, I welcome Padma Shri Dr. Shashank Joshi to this COVID summit. He is a well-known figure in the field of medicine. He is consultant at Joshi Hospital, Lilavati and Bhatia Hospital, Mumbai. He is Chair International Diabetic Federation, Southeast Asia, immediate past Dean, Indian College of Physicians, President, Indian Academy of Physicians, past President, Research Society of Study for Diabetes in India and also the Endocrine Society of India. He is past President, API, Hypertension Society of India, Emeritus Professor, JAPI, Padma Shri awardee, more than 100 books and 1,000 recent publications are in his name. Over to you, Dr. Joshi, sir.
Thank you, Dr. Nisar, sir. And I would like to thank the Maharashtra Medical Council for having this wonderful summit.
My topic is COVID care at home and red flags. So am I audible and visible?
Yes, yes.
Thank you. So at the onset, I would like to thank the entire team of Maharashtra Medical Council led by Professor Dr. Shiv Kumar Uttere sir, Archana madam, each and every council member, our very beloved Dr. Tatareo Lahane sir, and everybody who has been attending this meeting. It is not an easy job to talk about home care, but home care is the core of COVID care. And if you are able to do home care correctly, you can do it very well. But if you do it inappropriately, you can get all the blame. The person who introduced me is actually originally I belong to Ahmednagar, and I'm happy that Dr. Nisar introduced me. But home care is all about isolation, hydration, and food. Don't forget isolation, hydration, and food. A lot of people get dehydrated and land up in hospital. So it's very, very important that home care is a fundamental tool in primary care. And remember that when a COVID patient gets, COVID, look at whether that patient is having terminal illness, any very advanced chronic disease like dementia, COPD. Because when you are going to take decisions related to home care or institutional care, these are going to be very important for all of us as professional doctors, family and caregivers. And today we are in an era of digital health, as Archana madam was saying, that telephone calls, video calls, and also remember home care is also important for research. So what I'm going to talk after Dr. Pandit has given us a very nice overview in the hospital care is diagnosis and investigations. And of course, we have Dr. Fadke and Dr. Jhankaria who are going to allude to us on those areas, but I'll just make some passing references. What to monitor, the 7 vital signs to monitor at home. And then what works and what does not work in treatment options, because there is so much of confusion. What was true in the first wave is not true in the second wave and may not be true in the third wave. And then what are those red flags? What should be the transfer and triage is what Dr. Utturu sir, when he called me a couple of days back and told me that I should speak on this topic, he really focused on this point. He says, we want as medical professionals to know what are the red flags, when to transfer, when to triage, and maybe 1 or 2 simple take-home messages. So in order to understand home care, we must understand fundamentals of this simple tiny RNA virus. When this RNA virus, which now we know is clearly airborne and it is droplet airborne, gets trapped into our lungs, our nose, our throat, and we know we have a nose COVID, we have a throat COVID, we have a lung COVID with normal oxygenation. There are dual immune responses. One is the normal immune response, which 80% will get, which will be timely, innate, adaptive, where a type 1 interferon will be secreted and the macrophages will efficiently clear the virus, and the Th1, the T helper cell 1 and the B cells will produce neutralizing antibodies. These are the neutralizing antibodies we want our vaccines to develop, and obviously the virus will be cleared out and there will be recovery. And that's what happens. It's a fast spreading strain in this current pandemic. It's a fast recovering strain with a low case fatality rate. But if we miss the bus on a red flag, then unfortunately, or if the human host fails, or if there is a high viral titer, there could be a blunted immune response, which means that the type 1 interferon is not made by our cells of the immunity. There is endothelial cell death, epithelial and endothelial leakage, and our T cells, which are the T lymphocytes, the natural killer cells, the NK cells, which will get overactive or exhausted, and the macrophages will accumulate, and you will get something which is a cytokine storm, which Dr. Pandit was alluding to. So typically, there are 3 categories of what is going to be COVID. We all know that 80% is self-limiting. Whether you treat or you don't treat, 80% will be self-limiting, and that's the big problem. Because it's the 80-20, and those 20%, if you have to pick up, who will get severe COVID, and in that 1 or 2% will unfortunately succumb, is the real art of medicine. So remember, the art of medicine is very much alive as much as the science of medicine. So the stage 1, as COVID progresses in natural history, is asymptomatic, pre-symptomatic, and that's really the challenge, where you need to pick up that occult happy hypoxia, where there is innate immune activation, the virus will engage into the PAMs, and there will be a very low but type 1 interferon response. The stage 2 is the second stage. This is the tricky stage. It is non-severe but symptomatic. There is adaptive immune activation. a lot of specific antibodies like IgM is produced, T cell response is produced, and a release of DAM. And then ultimately it is the triple C syndrome, which is severe respiratory inflammatory, where there is cytokine release, coagulopathy, and complement activation. Today we are living in an era of evidence-based medicine, and the United States National Institute of Health for COVID has put out these levels of recommendations and strength of evidence. So when we talk of recommendations, A is strong, B is moderate, and C is optional. Unfortunately, strong evidence base is very little and scant in the COVID space. The moderate space and the optional space actually is overwhelmed, and many of them are anecdotal. And then there is a rating of evidence. For example, level 1 is one or more randomized control trial without major limitations, because a lot of COVID trials, even in the RCT space, have major limitations. 2A is other randomized trials or subgroup analysis of randomized trials. 2B is non-randomized trials, observational data, and of course 3 is expert opinion. So obviously, let's look at now how do we go further. To diagnose COVID, we definitely need, and this is what Dr. Phadke will allude to, nasopharyngeal, nasal, oropharyngeal specimens of the NAT, nucleic acid amplification test. He will allude to that. And remember, ideally, as per the level of evidence for diagnosing acute COVID, it is A3. And the NAT should not be repeated in an asymptomatic patient within 90 days of previous SARS-2 infections. The level of evidence is B3. And the NIH panel recommends against the use of any serological antibody testing for diagnosis of SARS-CoV-2, A3. So obviously serology has no role, and obviously the various RT-PCRs, rapid antigens will all be discussed by Dr. Phadke when he talks about it. Our Honorable Chief Minister said that we now have 3 types of COVID we are dealing as doctors. First is COVID happening for the first time in your lifetime without any vaccination. So that is some people call it virgin COVID, but I call it the naive infections. Naive means first time infection. It's called COVID for the first time without vaccination. Second is the breakthrough COVID. Breakthrough COVID means somebody who has taken 1 shot or 2 shots of the COVID vaccine. It could be any vaccine, but the vaccine failure, as it is called as. Actually, it is not vaccine failure. These are early generation vaccines. Tomorrow you will have a type on COVID vaccines. These are early generation vaccines. So they prevent mainly severe COVID or death, but they don't prevent the infection. So that is called as the breakthrough COVID. And you know that the incidence of breakthrough COVID, as per Indian Council of Medical Research, is very low, 0.04, 0.02. But in the healthcare space, which is the space in which we all work as doctors, we see a larger proportion of it happening, because you know that 16th of January was the one healthcare workers started getting their vaccination. Most of us have got 2 shots of vaccines. And I would still encourage those who have not, don't have hesitancy, go and get a vaccine done, because at least you will not get severe COVID or the death. But one thing is definite, that I would like to pay my homage to all our brothers and sisters who have lost their lives, whether they have been vaccinated or not in this whole COVID battle. We know that we have lost more people than Kargil war across India and across the world. And the third is a very rare subtype called reinfection. I have had many patients who got COVID in the first wave and now have got COVID again. Because remember, the viral strain of the first wave is different from the viral strain of the second wave. So very rarely, again, it's a very, very 0.001% chances that occasionally you can get reinfection. And usually this is also without a vaccine. So there are 3 categories of COVID: naive COVID for the first time without vaccine, breakthrough COVID where the vaccine is failed, and reinfection. All 3 possibilities exist. So what are the biomarkers? Now, I don't again want to go into biomarkers in depth and detail, but when you are at home, usually if there are persistence of symptoms on day 3 to day 5, you can do some biomarkers. And Dr. Phadke will again allude to them in details. But in the blood chemistry, a simple complete blood count, if you see the red cell width is more than 14.5, this patient is likely to deteriorate. Okay, of course, you look at the lymphocyte count. If the lymphocyte count is very low, there's lymphopenia, that's a poor sign. If there is a platelet count which is low, and we are seeing some thrombocytopenia now in COVID care, again, it's a poor marker. And then we do another test called neutrophil lymphocyte ratio, NLR. So in a simple complete blood count, which is available across everywhere, if you see the red cell width is more than 14.5, or if the neutrophil to lymphocyte count is more, or if the platelet counts and the lymphocytes are very, very low, then I think you should have a red flag. And in that red flag, probably you may err on the safer side try to consult with a physician or ID specialist, and maybe you might take a decision of transferring or triaging the patient out, which we'll allude to. Then lot of biochemical markers are being studied. So what is put out in the yellow in this slide are the ones which are known beyond reasonable doubt with evidence base, while others which are there in the yellow are the lighter yellow are the ones which are under investigations, and the ones which are green are proven beyond doubt. Then of course you have biochemical markers like the liver enzymes, the LDH, the various other cardiac enzymes, and we don't do them as routine. LDH definitely has some yield, but don't do it as a package all the time. Even if your LDH is high, definitely it's a red signal. Then of course D-dimer. If the D-dimer is high, you know that many of these patients will need a prophylactic, not therapeutic. There is data now to show from the American Cardiology Congress last week that there is no role for therapeutic anticoagulation, but there is a clear role for prophylactic anticoagulation, preferably by giving a low molecular heparin if the D-dimer is elevated. But D-dimer is also a very, very tricky test, and I'm sure Dr. Fadke in his talk will allude to that. And then of course is CRP, ferritin, PCT, IL-6. These are expensive tests, but CRP cheap. So if you have to pick up two tests in primary care or family physicians, I would say just do a CBC and a CRP. If the CBC shows RDW is more than 14.5, or the neutrophil to lymphocyte ratio is high, or if the lymphocyte count, there is lymphopenia, there is thrombocytopenia, and the CRP keeps going up every 3 days, obviously that's a telltale sign that you may need institutional care. If you get additional facilities of LDH, ferritin going up, D-dimer going up, IL-6 going up, it may be useful, but we don't recommend it as standard of care. All other tests which are recommended here, including homocysteine, are all under research mode. So remember that simple CBC CRP can do it. So the main thing in COVID care, and this is a slide which my good friend in the task force, Dr. Banjan, has made, assess, triage and transfer and manage. It's very, very important that whether remotely or physically, you assess the patient. If you are in doubt, call the patient to an emergency room or a casualty. So assessment is the first stage. Then immediately you have to take a decision on triage and transfer and manage. So that is the typical ATM approach. So what do you assess with? Well, these are the 7 vitals to assess on home-based care. One is temperature. You need to monitor temperature every 6 to 8 hours. Try to keep the patient afebrile. Keeping the patient afebrile in COVID is very, very crucial. If there is one important sign beyond oxygen saturation, it is pyrexia. If your patient is having persistent pyrexia beyond 3 to 5 days, either you need to give that patient a monoclonal nitric cocktail of antibody, or you need to shift that patient, because persistence of fever is not a good sign. And try to give round-the-clock paracetamol, because giving round-the-clock paracetamol is equally important. And you can give 650 milligram 3 times a day to 4 times a day paracetamol, and that is something which is need of the hour. Because if there is persistent pyrexia or there is persistent fever, you will get tachycardia. And if there is underlying cardiac disease, that will get aggravated, and sometimes you may lose the patient with a cardiac disease. So it's very, very crucial to maintain normal temperature, and if needed, give paracetamol round the clock. Please don't hesitate that. And if there's persistent of pyrexia beyond 3 to 5 days, again, that's a red signal that you might need to shift it to a facility. Second is pulse. If there is persistent tachycardia, and this can be very, very troublesome, that has an ominous sign. So persistent tachycardia will clearly red flag you to move the patient out. Many patients, even after they come back after 3 weeks, get a sinus inappropriate tachycardia, which is an autonomic dysfunction of moderate to severe COVID. That we'll discuss a little later. But remember, if you are seeing the person for the first time, there is persistent tachycardia, pulse rate is above 100 all the time, in consecutive readings, it's a sign to triage the patient out. Respiratory rate is not easy to measure. Sometimes we tell the patient's relative to put, and also remember when the patient is at home, ensure that double masking is done by all the family members, and there is appropriately, the isolation is done, and respiratory rate is above 24. Again, it's a red signal and alert, and shift the patient out. If the blood pressure is above 140 and 90, alert, but administer blood pressure medications. And then of course is oxygen saturation. And if the oxygen saturation at baseline is below 93%, you need to shift. That's the single most important tool. And a simple 6-minute walk test with a 3% drop also, you will shift the patient. Also remember, the 6th vital sign often is glucose. Many people, whether you have diabetes or no diabetes, if they have a glucose testing machine at home, they should just simply measure their glucose. And if the glucose is trying to be maintained at 140 to 180, if there is a persistent high hyperglycemia is there, shift that patient out because outcomes will be poor. You will often need insulin. And maintain digital connectivity and telephone. And don't talk just to the relative. Talk to the patient directly. Just by simply talking to the patient, you may realize that the patient may be sick. Patient may not be able to, maybe out of breath just talking to you. You know clearly that this patient needs to be moved. So these are the simple 7. If there is persistent pyrexia, tachycardia, tachypnea, hypertension, desaturation, hyperglycemia, and be connected with the patient, because from that you can clearly know whether the patient is toxic or not toxic. We can easily make a video call to the patient through our telephone mechanisms. Symptoms, as I told you, are persistent fever. If somebody is having persistent fatigue, dry hacking cough which doesn't go down in 5 days, again, that's not a good sign. If somebody has shortness of breath, that's not a good sign. Remember, loss of taste and smell is sine qua non with an RT-PCR. If you have loss of taste and smell, and usually the recovery is a rule. Exceptions can occur, but remember, if there's loss of taste and smell, recovery is a rule. Aches and pains can occur, nasal congestion, runny throat, sore throat can occur, diarrhea can be a symptom. Travel history, now we know it's community spread, so it really doesn't matter. And if you're a healthcare worker, you need to be more alert. So that's something very, very important. But the main assessment is to detect that occult or happy hypoxia or the hidden hypoxia. And remember, sometimes COVID mimics can come up. Often in the last wave and this wave, we have seen COVID patients first time presenting with a heart attack or an acute coronary syndrome or unstable angina. First time a COVID patient presenting with a stroke or a seizure or even a diabetic ketoacidosis. So remember, you can get these COVID mimics all the time. So remember, in the COVID times, presume every patient to be COVID positive until proven otherwise. So there is a simple national early warning score which is available on the app. And it picks up simple things like respiratory rate, saturation, air and oxygen, systolic blood pressure, pulse, consciousness, and temperature. And will tell you whether you need to immediately move the patient or maybe move into the ward and so on and so forth. Now, important thing is we are basing everything on pulse oximetry. And pulse oximetry is the key for home care. So remember that there is very good data across the world to show, and this is not an old thing. Pulse oximetry has been there for a long time to pick up the silent hypoxia. So the ease of use and the low cost of pulse oximetry has led to a springboard of pocket oximeters. But do not rely on smartphones. A lot of people, and I have seen mistakes being made by a lot of our professional colleagues that do not rely on any smartphone oximetry. Many times patients tell you that they are using their oximeter correctly. Those have to be really highlighted, because key to home care is your reliance of appropriate use of the oximetry. And therefore, it's very, very important to recognize that do not rely on any smartphone-based systems for accuracy. It's important to remember that there can be very, very lot of errors in pulse oximetry due to rapid fluctuations. So if you are in doubt, measure it appropriately and correctly. Because remember, the arterial oxygen pressure and tension falls with a steep proportion of a dissociation curve. And if the pulse blood flow is diminished, if there is severe hypoxia, there is a hemoglobinopathy, so many other problems, you can get a false reading. So remember, all pulse oximeters give you an approximation of arterial oxygen saturation, which is the percentage of hemoglobin binding sites occupied by oxygen, which in turn is PaO2, as defined by the hemoglobin oxygen dissociation curves. And devices measure this in different ways. So when you are monitoring saturation at home, individuals, we should be at rest first. Breathing quietly without talking for several minutes. Many a times, if they are alone at home, we tell them to take off their mask because that mask itself may desaturate it. So remember, let that person rest. Let that person breathe quietly for several minutes. Measurements should be made indoors where device is seated securely on the middle of the ring finger, not a earlobe or a toe. Nail polish must be removed from the finger on which the measurements are made. And if there are cold extremities, because sometimes people are in the AC, they must be warm prior to the measurement. Rather than accepting the first number which appears on the screen, individual must observe for 30 to 60 seconds. Wait for a minute so that you can get a commonly measured value and then accept that value after there is a good strong pulse signal. So the pulse signal has to be strong. So that's the easy yardstick of a pulse oximeter. And you try to measure these values multiple times of the day so that you can know the gauge the trend of the oxygen saturation. So the 6-minute walk test for saturation has a very high yield to pick up and diagnose people and red flag them. So you need to do the signaling. And when you are doing the signaling, whether it's a red signal or the yellow signal or the green signal, that is the principle of triage. So obviously, if the patient then has to be moved and is safe but is unstable, then you need that if the person is COVID suspect and needs a ICU care or a non-ICU care, or is it stable, does need isolation in the wards, or has something else, non-COVID, because we are in non-COVID times. So you might have an alternative diagnosis. Somebody might have an appendix, which may need a removal. Somebody may have an acute abdomen, which may need an removal, like Dr. Utture might have that case. And somebody might have an acute medical abdomen, which might still need care. So remember that we are still needing to triage them, whether they are in the red zone, the yellow zone, or the green zone. Now, the red flags again are news score. If the news score is more than 5, if a single news parameter is more than 3, if there is sudden onset of breathlessness, or if the 6-minute test is positive, that's a red flag. And you need to move the patient immediately. And that is the time you may have to do multiple things. You might have to see the emergency room or the casualty, do an HRCT if needed, which Dr. Bhavin will tell you, do a focus and provide oxygen there. So remember that you need to ensure that a decision of transfer, there are many things. Does your patient need oxygen? Does your patient needs, as Dr. Rahul was saying, any NIV or mechanical ventilator or ICU care? Ensure that the destination hospital and relatives are kept in the confidence. Do not transfer last minute. At the same time, do not ensure that the patient is transferred too early also. Ensure that the ambulance, personal, PP is taken care of. One thing is very clear, all over the world they have said, early and appropriate hospitalization is equal to less mortality. So to save lives, this is very, very crucial. And for that, you need to triage the patient, whether the patient is in mild COVID, moderate COVID, or severe COVID. And these parameters Dr. Pandit alluded to very nicely. So when you're managing somebody outpatient at home with COVID, it's all about supportive care. And the level of evidence for supportive care for COVID outpatient is A3. And you need to, first thing is isolate the patient and be in constant touch with the healthcare provider and seek inpatient evaluation. The symptoms need to be triaged, and we need to see if there is somebody with dyspnea, then obviously, and if there's worsening of respiratory status, move the patient. So dyspnea or breathlessness, move the patient. Level of evidence is A3. And try to monitor vital signs, physical examination, progression of severe illnesses, and availability of healthcare resources. So the COVID timetable is 14 to 21 days. And the post-COVID timetable is 100 days or 3 months. So it is the right approach, right time, and the right medicines. So should we use antimicrobials? A lot of people will ask me a question, should we use doxycycline? The answer is no. There is no data to document that doxycycline works in COVID care. Should we use azithromycin? The randomized control trial done on azithromycin in COVID care has been negative. But if doxycycline is needed for, say, a leptospirosis, azithromycin is required for a non-COVID LRTI, you may use it in a rational way. But as far as COVID is concerned, neither doxycycline nor azithromycin have any role as far as COVID is concerned. The RCTs done on them are negative. Is there any role for anti-parasitic agents? Like the commonest one being documented is ivermectin. It is still in a research mode. It is not a standard of care. You can give it 12 milligram BID for 5 days. We have also done some trials, but it is still not a standard of care. So, we don't have that level of evidence to suggest that it could be useful. What about favipiravir? What about remdesivir? Where if you use favipiravir in the first 3 days, the virus may be cleared fast. However, there is no data to show that favipiravir saves life. It changes the outcome of COVID. But if there is high viral load, if you use it early, hit hard, hit early, it may benefit to clear the virus faster. Similarly, remdesivir part, Dr. Rahul Pandit said, if you have moderate to severe COVID, if the person needs oxygen saturation with steroids, remdesivir may have a role in the first 9 days, used for 5 days. So that's where these agents start. So as far as home care is concerned, these agents have a very, very limited role. Though many of us write it, I don't think the data on that or the RCT evidence based on that is very high. Insist to speak to the patients on the phone because it will identify whether the person is toxic or not toxic, and the patient is not up to the mark, it is okay. So all patients who are having desaturation of 94% or symptoms of high acuity, which means if your COVID patient is having chest pain, tightness of chest, dizziness, confusion, mental status change, refer the patient. Do not wait. If you have a senior citizen, elderly patient, or person with underlying comorbidity like obesity, diabetes, hypertension, heart disease, kidney disease, liver disease, transfer the patient and ensure that the ambulance care is taken care, because otherwise many a times lives are lost in that. So remember, these are the red flags: desaturation, chest pain, tightness, dizziness, confusion, mental status change, senior citizens, comorbidities, and ensure that ambulance care transport is done properly. Dr. Rahul left this point to me. We are having a breakthrough therapy, which one of the ex-US presidents was given. It is called as the anti-SARS-CoV-2 monoclonal antibody to treat outpatients with mild to moderate COVID. And the agent he referred to was casirivimab and indivimab. It's a combination like tick cocktail, which is available. Level of evidence A2A, very high level of evidence. In the first 72 hours, if you give this injection, it can be given subcute or IV in an emergency room. Okay, it can actually 70% hospitalization can be saved. And this was given, it's used in the US. Now it's available in India. It's only 60,000 rupees. It's very expensive. It is for people who have high risk of clinical progression. 2 weeks back, Government of India approved it. Last week, it has been available in India. I don't recommend it as a routine care, but people who are in high risk category, for example, somebody who has cancer chemotherapy undergoing, somebody has immunological diseases, somebody is having a lot of comorbidities like chronic kidney disease and is elderly, obese, diabetic. In them, this monoclonal antibody, if used on time, can be life-saving. There's data to show that. There is no data on chloroquine, hydroxychloroquine, so it's more or less out. Whether it is recommended or not, the level of evidence on that, and with or without azithromycin. There is no role for dexamethasone or systemic steroids in outpatients in absence of another indication. So if there is no other indication required, then again, A3 level of evidence, there is no role for steroids. There is no role again for antibacterial therapy like azithromycin or doxycycline, A3 level of evidence. So again, this is very, very clear. I'm saying it again and again, but there might be some investigational therapies. Ivermectin is an investigational therapy. It comes in that category. Again, the level of evidence there, or even favipiravir is an investigational category agent. So virtually there is hardly any drug which can be used. There was a passing mention by Dr. Rahul Pandit on inhaled budesonide. Inhaled budesonide also has not to be used unless and until there is persistent cough for 5 days at home. And Dr. Ramakrishnan showed this in a prospective randomized phase 2 trial where he took 2 puffs of 400 micrograms of budesonide twice a day, inhaled, in only 146 adults within 7 days of onset of mild COVID symptoms. And when they tried these patients, they found that early administration of inhaled budesonide in COVID patients reduced the likelihood of urgent medical care and enhanced clinical recovery. So the task force recommended this, that it can be used only if there is persistent cough, but it has put a caution mark on it. So it is not a routine care. And we already know that inhaled budesonide is out of stock. So it is not a standard of care, but is a reasonable agent if there is persistent cough, and you should use it appropriately. But again, there is no role for oral steroids. He also made a passing reference to another agent, which is a gout agent called colchicine. And the Colcorna trial just got published 3 days back. The Colcorna trial is what colchicine in community-treated patients, which is home-treated patients. Randomized, double-blind, adaptive placebo-controlled trial. This was done in Brazil, Canada, Greece, South Africa, Spain, and United States. It was led by the Montreal Heart Institute. And what they did is they gave colchicine 0.5 milligram twice a day for 3 days, and then one daily for 27 days after that, which means 30 days they gave colchicine. Okay. And the trial was showing that it did not have any major impact. There was no any significant statistical impact, but there were some marginal endpoints which were improved. And the COVID patients with colchicine had lower rate of composite death or hospital admission. So the death was lower, hospital admission was lower, and therefore what they recommended, and the conclusion, the Lancet paper wrote that given the absence of orally administered therapy to prevent COVID complications in community, the benefit of colchicine is safe, inexpensive anti-inflammatory agent, which could be considered for use at risk for complications. Task force has made a passing remark that one can use it if needed, but it is again an emergency use authorization, and this trial just got published 2 days back. So colchicine may have a role, but as I said, the verdict on that is still not out. So that is something for us to look at. So what determines who will deteriorate? It is how fast the virus is replicating, how strong your immunity and inflammation is going to occur, and various other factors which we'll not discuss. This is a slide Dr. Pandit also showed you, that the first phase is the viremic phase, where there are constitutional symptoms. It's all about paracetamol, maybe persistent cough, about inhaled budesonide, and monitoring the patient. It is that 2A and 2B where the desaturation occurs. And that's the time you need to put the patient in the hospital and probably administered either them a remdesivir or a steroid and oxygen, and maybe some low molecular heparin. So obviously, if you look at it, the therapies in the hospital, Dr. Rahul Pandit alluded to, were basically low molecular heparin, steroid, but at home, there is no role for either of these agents. And that's very, very clear cut. Okay. And antiviral therapy, we know that favipiravir is questionable, so we don't recommend it as a standard of care. Remdesivir is also questionable, it has been taken out. And we know that it's all about communication and transfer. So obviously, it's all about monitoring the 7 vital parameters. It's all about the red flags. If you are in doubt, transfer. And it's very, very important that the asymptomatic patients take care of their mental health. After 7 days, they get restless. All patients deteriorate between 7th day to 14th day. You also get a delayed storm as late as 16 days. And that's the time they falter, they don't monitor their saturation, they suddenly deteriorate, and then they're brought dead to the hospital. And home precautions for family members is equally important. Post-COVID, you have to look out for fibrosis, the heart disease, the diabetes, the neuromental care, the fatigue, and so on and so forth. So lifestyle is equally important. So eat less, but eat on time. Eat a large meal. Eat right. Try to do some physical activity and stay positive, but good 7 hours of sleep is equally important. Hydrate. Ensure optimal calories and adequate protein is there. Try to do a digital detox and ensure that if you are staying at home, be safe and be clean. You need to ensure that disinfection is done, because you know that this pandemic, a lot of home isolation has been moved to institutional quarantine because of the cluster spreading of the virus. And I am sure a lot of appeal was there that why has there been institutional quarantine, which has been used by administration. Probably the reasons for that are two, because it's a cluster spreading virus. And probably people are sure that they are not able to identify the red flags. And that's very, very crucial. If you identify the red flags correctly and shift the patient on time, then I think you can save a lot of lives. But remember, if you can manage them successfully at home, that is the key to COVID care. So remember, COVID treatment is there, but we need to be very responsible. COVID is predictably unpredictable, but we need to save lives. And I'll be happy to share any information you want 24/7. Just send me a mail on my mail. And I really thank Dr. Utture and his team, Archana Madam and her team, Dr. Lahan and his team, for allowing me to speak on home care, a subject very passionate to my heart. And we all ensure that we want to keep our patients safe. 80% of people can be managed at home. In fact, 90% of the patients can be managed at home. But if you are in doubt, and however simple or stupid the doubt is, just transfer the patient and ensure that you save every life. Every life matters. And I think now we understand COVID a little better than before. And we have better home care options, including medications available to us as doctors. Thank you very much for patient hearing.
Thank you, Dr. Joshi, for your excellent presentation on home isolation and red flags. If followed by all the doctors, definitely the mortality rate will decrease. All the points you have elaborated very well, and there are no doubts in the minds of the audience, anything, and there are no major questions. Only one small question is there, that if the patient dies in home isolation, will there be a MLC case?
That question, actually, Dr. Utture is a better person to answer than me. But I think if he's an asymptomatic patient, I think you are well within your rights, and he has monitored it appropriately, and he dies suddenly, I don't think there will be any challenge. It's all about how connected you are in care. And I understand that doctors have been at the receiving end in the pandemic times. I am as much with you, Dr. Sheikh, as and we have all taken this, and which is why you have seen that a lot of uproar was there when in, I think, 14 districts of Maharashtra, they said that there has to be institutional quarantine. Minute they say institutional quarantine, there is a big resistance, and the responsibility is put back on the doctor. The doctor has to take the decision. And the red flag is on the doctors. The gun is fired on us. And I think you all are the council. I can see my good friend Dr. Bakulesh Mehta smiling. And it's not easy to handle this. But I would ask Dr. Utture sir to give this answer. But I think if you ask my medical opinion on this, if you have done everything correctly and documented everything correctly, you will not be blamed for any MLC. Misunderstandings can creep up. It's all about communication. Ultimately, if you are in communication, many a times what happens, patients falter on communications and they backtrack. And there's too much of panic, too much of negativity. What has happened is most people, for the first 7 days, they try to manage themselves. म्हणजे आपण मराठीत म्हणतो अंगावर काढतात आणि मग अंगाशी आलं की डॉक्टरवर टाकतात. असं होतं मात्र. म्हणजे मी आता अगदी स्पष्ट बोलतोय, मराठीत बोलतोय, सॉरी आय एम टॉकिंग इन मराठी, बट people try to take it on their own. And it all happens between the 7th and the 12th day. And we have seen this in the last wave also and in this wave also. But I think if you are communicating appropriately, we can save many of these mishaps. And documentation is the key, is what I personally feel, both from a medico-legal angle and from whatever little experience I have. I'm not as experienced as Utture sir or Mehta or Dr. Lele sir or you, Dr. Sheikh. So maybe you all are in a better wisdom to answer this question, but I would request Dr. Utture to give a short answer because it's a very, very important question. And I think we can be at the receiving end. Many people will get confidence after hearing my talk that, we can manage everybody at home. And then if something happens wrong with them, they will say, Dr. Joshi, you told us all this beautifully, we managed, and now look, we have landed up with a problem. So, this is but document it. Whatever advice you are giving, document it. I write it on a piece of paper and tell them, monitor twice a day temperature, monitor twice a day oxygen saturation, be connected with the healthcare worker, and write it down, take a picture of that, send it through whatever mechanism or medium you can. And if you are able to document it properly, I think there should not be a problem. But more than documentation, communication is the art. And I think if you are communicating appropriately, and the family doctor, there is some degree of trust. So I think if we are able to do that, I think we can mitigate that. But I still would like the wisdom of Dr. Sheikh, you and Utture sir, both of you all, to answer this.
Yeah, I think if I can answer that, very pertinent question, but let me tell you, Maharashtra Medical Council, Dr. Joshi, we have already discussed this, and a resolution has already passed in the Maharashtra Medical Council that anything done in good faith and you have followed the protocol, and if anything happens to the patient, you will not be held guilty as far as ethics is concerned. That has already been officially passed by the statutory body, the Maharashtra Medical Council. Of course, that will not stop the litigation, but definitely it is going to protect you if you are going to follow the protocol. So that care we have already taken in the council. Thank you.
Thank you, sir. Thank you, sir. Thank you for the opportunity.
Over to you, Archana.
Yes, sir. Thank you so much, Dr. Joshi. I think people will be better versed with home isolation guidelines now. And I think the key is basically to time the symptoms. What is most important is to time the symptoms, the onset of the symptoms, and from there, the second week from the onset of symptoms is where, if you were to pay the maximum attention on the patient and assess them at every visit, maybe you will be less likely to make a mistake. So this is the take home I think we take from this beautiful lecture given by Dr. Shashank Joshi. And now we move on to our third session of the day. And I sincerely apologize to everybody for running behind schedule. Radiological studies have proved to be a very important diagnostic modality to identify COVID patients, differentiate COVID from non-COVID, the extent of lung involvement in COVID, identifying complications associated with COVID like thromboembolism, myocarditis, etc., and also for the follow-up cases. To brief us on the importance of imaging modalities in COVID, we have with us Dr. Bhavin Jankaria. I invite Honorable Council Member Dr. Ashok Tambe sir to introduce the speaker and chair this session. Dr. Tambe sir is an anesthesiologist, CWC member of IMA Headquarter, past President IMA Maharashtra State, Director Indian Red Cross Blood Bank Baramati. Sir is also an advisor to IMA Maharashtra State Chapter. Over to you, sir. Please carry forward the proceedings.
Thank you, Archana. Dr. Bhavin, welcome to this MMC COVID Summit. On the behalf of Maharashtra Medical Council, President Dr. Utture and all other colleagues, I welcome you in this very important COVID Summit and very record break registration, more than 20,000. So I congratulate Dr. Shivkumar and Archana and all my colleagues. Dr. Bhavin is a known consultant in radiology and is a trustee for Radiological Society. Then he is a past president of IRIA and also past president of Indian Musculoskeletal Oncology Society. He is a honorary visiting consultant to Tata Memorial Hospital in Kolkata. He is the ex-editor of IRA journal, and he has submitted many journals, and he is very good speaker. So without wasting much time, because we are short of time, I welcome Dr. Bhavin and give mic to him. Dr. Bhavin, please.
Hi, thank you, Dr. Tambe. Thank you, Archana. Thank you, everyone from the MMC, Dr. Utture, and all the other speakers who are here. It's a privilege to be speaking in this August gathering, and I believe we have a record-breaking number of delegates who are attending this. So I'm just quickly going to go ahead with the topic. Archana had discussed this with me in detail. And the idea today is to just speak about the importance of imaging modalities in COVID-19. And so the modalities that we have are CT and MR, and CT can be used in the chest, abdomen, head and neck, and MR we use in the heart, brain, and head and neck. And I believe the head and neck, especially in relation to mucor, will be covered tomorrow in detail as well. So let's spend some time on CT chest. What we will cover are the signs, classification system, severity scores, differentials, the concept of angiopathy or vasculopathy, and a little bit about the follow-up that we're seeing now. These are the common signs that we have. We will spend a little time on CORADs and then the rest as mentioned here. So we all know, and most people have seen CT scans in patients with COVID. The primary finding is the presence of ground glass, which is increased opacity that does not obscure the underlying vessels. This ground glass can be central. It is usually perivascular, and it can be at the periphery as well. But even at the periphery, subplurally, it's often perivascular. And that's, in fact, a defining feature of the ground glass that we have in COVID. Now, if this ground glass is associated with these septal lines and thickening, we get this crazy paving pattern, which earlier we used to only see in alveolar proteinosis, but now this is again a defining feature of COVID-19. We can get consolidation over and above the ground glass. This consolidation is increased opacity that obscures the underlying vessels, as against in ground glass where you see the vessels through the ground glass. And most of the times we have ground glass and consolidation coexisting. The consolidation usually has an organizing pneumonia pattern. We can get consolidation with a ground glass halo, or we can have ground glass in the center with surrounding consolidation, which is called the reverse ground glass or the atoll sign. The earliest sign that we see is this perivascular ground glass. We see this in asymptomatic individuals. Sometimes patients just walk in and want to get their CT scans done, and this is generally what allows us to make the diagnosis. A week or 10 days down the line, we start seeing these bands. They can be thin or thick. We now know that the lung that subtends the band is usually hypoperfused because of the angiopathy, and that is the reason we get these edematous bands. Now, when the disease progresses, when there's a cytokine storm, as Dr. Pandit spoke about, or the patient becomes more severe, or the disease becomes more severe, then we start getting bilateral extensive involvement. Typically, the anterior segments of the upper lobes are often spared, as we see here. And then there is bilateral ground glass and consolidation. Often we get mild pleural effusions as well. And when we get this pattern of lung involvement, it can lead to quite disastrous consequences for the patient. And it's quite tough to bring them out of this. Some of these patients have had postmortems done, especially outside India, and they found a combination of diffuse alveolar damage, AFOP, fibrosis, and OP patterns. Now, once we've understood the patterns that occur in COVID, when we write the reports as radiologists, we need to mention the confidence that we have in saying that this patient has COVID. And so the one confidence system that has become very popular in India is the CORAD system, where if I say that this patient has CORAD's 5 disease, it would mean that I'm extremely confident that this is COVID. And if I say that it's CORAD's 1 or 2, it means that it's highly unlikely that there is COVID. So this is not a scoring system. This is a confidence system. So when the scan is normal, it's CORAD's 1. When there are findings, but these are due to a non-COVID disease, like in this case, we see tuberculosis, then it's CORAD's 2. CORAD's 3 is where we have findings, but we're not sure whether it is something else or COVID. So these are truly indeterminate. CORAD's 4 is where we have findings highly suggestive of COVID, but the distribution may be atypical or the disease may be mild. And CORAD's 5 is where we have classic typical findings. And so these have all been validated. Typically, when we say CORAD's 5, the specificity is almost 93 to 94%. And this can be better depending upon the radiologist or the hospital. And even in asymptomatic patients, if we say that a patient has CORAD's 5 disease, the specificity can go up to as high as 98%. So whenever we see a CORAD's 4 or a CORAD's 5 in the report, it means that the patient almost certainly has COVID-19, irrespective of the positivity or not of the RT-PCR report. Now, over a period of time, there's been a lot of controversy about how good CT is or not. And the Cochrane review is a live review. So every 2 to 3 months, they are constantly revising it. And the latest review that was, I think, about 3 weeks back, and this is a worldwide review, shows that CT has an 88% sensitivity and 80% specificity. But again, this can be much better depending upon the radiologist or the hospital. Let's move on to severity scores. So again, the radiology report, apart from the description, apart from the CORADs, will also have a severity score, usually out of 25. So 95 to 98% of diagnostic centers and hospitals follow this. There are some outliers who use their own systems, and ideally the physicians should tell them not to do that, because it's important to maintain a certain level of equality in our reporting systems. Now, this is a semi-quantitative scoring system, and I'll show you very briefly how it is done. So we divide the lung into 5 lobes: right upper, middle, lower, left upper and lingula together, and the left lower. And then we try and see whether the lung is less than 5%, 5 to 25, etc. So here, for example, the right upper lobe is not involved, so the score is 0. The right middle lobe shows very subtle involvement, less than 5%, score is 1. The right lower lobe shows these areas of ground glass. Clearly, it's more than 5, but less than 25%, so the score is 2, and so on and so forth, until in this patient, we come to a final score of 8 by 25. We must remember some of the fallacies here. Remember that it's 5 to 25% is 2, which means a patient who has 20% involvement in all the lobes will still have a score of 10. And a person who has 8% or 10% involvement in all the lobes also has a score of 10. So if you've understood the fact that you can have a range, right? A person with 20% involvement is twice the involvement of a person with 10%, but the score remains the same. And therefore, clinical evaluation is equally, if not more, important. Also, this is not truly a severity score. It is an extent score. What we are saying is the extent of involvement of the lung. We're not commenting on the extent of consolidation versus ground glass. If we have consolidation, that's a worse prognosis than ground glass. So none of that is there within the score, but nevertheless, because the score is widely used across the country, we now know that a severity score of more than 15 or 18 predicts a worse outcome. Basically, the higher the score, especially above 15, we need to start aggressively managing the patient. And so we need to understand that this is an extent score and not a severity score. And then we have differentials of the various patterns like the OP, ground glass, AIP, ARDS, etc. These are the various conditions that can simulate or look like COVID. Here are 6 images that I have put. Again, once we take the clinical situation into account and the history, etc., usually we are able to differentiate among these entities and COVID. Let's spend a little time on angiopathy and vasculopathy. And while we keep talking of this being a viral pneumonia, we know that primarily this is an endothelitis. And a lot of the findings that we see on CT are a result of the endothelitis. And the first paper on this came out in April 2020, where Dr. Udker talked about one patient who had COVID, no thrombi in the pulmonary system, D-dimers were low, but the patient had perfusion defects suggesting a vasculopathy. And again, there have been post-mortem studies. There's been a study where they've done cryobiopsies in active COVID patients in Italy, and they've all shown that this is a primary vasculopathy. So what are the CT signs of the angiopathy? Proximal dilated vessels, intralesional dilated vessels, the vascular tree in bud where we see this vessel with these buds coming out, which are the microthrombi, the target sign where we see the vessel, then we see the perilesional edema, the hypoperfused normal looking lung, and the surrounding edema. So that tells us that we're dealing with a vasculopathy. Now here we see bubble lucencies on the soft tissue. Here is a target sign, and the patient actually has frank thrombi as well. So we know this patient has a vasculopathy, but remember, we can get perfusion defects without the presence of thrombi, as we see this normal CTPA, but abnormal perfusion scan. This patient came 3 weeks after the onset of COVID, and then we did a CTPA because things weren't looking very good. And we see that in the mid zones, there is hardly any perfusion. This is all black, non-perfused lung, whereas there is hyperemia in the lower lobe. What this means, and does this change treatment? We're not really sure now. And this can happen later as well. So this is a patient who came 3 months later. Normal vessels, but extensive. All the black areas are perfusion defects, and here are the bright orange areas that show the hyperemia. And there's been one paper out now from the French group showing that in their severe patients, 2/3 3 months later had evidence of widespread microangiopathy on dual energy CTPA. So if for those interested, that's the list of signs that we have on plain scans and on the CTPA or contrast study that tell us that a patient has pulmonary angiopathy. Now that we are in the second phase, almost a year since everything started, we also have patients coming in for follow-up. Now, most of the times, as both Rahul and Shashank have said, most patients improve. So typically a week later or 2 weeks later, all these lesions have gone and there's just some subtle bands that are left. But we also know that some patients can deteriorate rapidly. So on the 23rd of April, there were about 4 or 5 small spots in the lungs. The patient had a cytokine storm. You can see significant disease now, which became acute lung injury. And now this patient has significant pathology in the lung. So we need to be careful of some of these patients. But what happens over the long term? Now, this is a patient 9 months follow-up from July to March, and we can see that there are residual reticular opacities, a little bit of traction bronchiectasis, and this is what many people call fibrosis. But the question that we really need to ask here is whether this is truly fibrosis or not, or whether these people can improve or not. So here, let me show you another patient who in June had this significant traction bronchiolectasis and what looked like significant fibrosis. But about 7 months later, we can clearly see here that most of this has regressed. And if we see the data from the first SARS pandemic, where the findings on the CT were the same, most patients 6 months later had significant improvement, and a paper that was published in 2016 for 7-year follow-up showed that the vast majority of patients tend to do well, both clinically and otherwise. So we don't use the term fibrosis, we use the term COVID sequelae, because we're not really sure of whether this is true fibrosis or whether these are just residual findings, and in some patients may take a little longer to resolve. So the indications have to be decided by the clinical situation. On social media, often there's a lot of fighting going on about whether CT is being overused or not, etc. Yes, if the scans are being done because of FOMO or peer pressure from WhatsApp groups and patients are asking for it, I think we should resist that. The rest of the times, the indications for doing CT scans are best left to the treating doctors, who are in the best position to decide whether the CT scan is required or not. Some interesting cases and issues that we face. This is a patient who came with COVID findings and has bilateral adrenal hemorrhage. This patient went into adrenal shock and passed away the same night. We weren't able to salvage the patient. Other infections can be a challenge. This patient had CKD, has COVID, had a mass in the upper lobe, for which we did a PET 2 weeks after. When the patient had recovered from COVID, there was uptake, so we put a needle inside. Turned out to be nocardia. Now, was this an infection related to COVID, related to the CKD? We're not very sure. TB can be a confounder. Here is a patient who has cavitary disease in the upper lobe, was put on anti-TB treatment. 2 months later comes with fever, and while the TB lesion has improved, the patient has landed up with COVID. Here, of course, that diagnosis could be made easily, and then the COVID findings regress. The patient actually did quite well. The TB findings have remained static, and obviously the patient is improving. Pre-existing interstitial lung disease can be a challenge. This is a patient with Sjogren's and NSIP. This is from 2019, came with fever. It can be very difficult to look for COVID lesions in a fibrotic lung. But in this patient, we had some lung that was not badly involved. And there we found the new perivascular ground glass, which told us, yes, this patient has COVID. And then the RT-PCR came positive. But the reverse can happen as well. So if the radiologist is a little inexperienced, as happened in this patient whose family had COVID, RT-PCR was negative for the patient, but she was still admitted because somebody called this CORATS 5. So this patient has RA-ILD, which had progressed. But even when we looked at this very closely, we could not find any evidence of COVID in the lungs. It was just progressive RA-ILD. Since so many CT scans are being done, we're now finding incidental lesions. So this is a 63-year-old, very mild COVID, did very well. But that same CT scan showed a lobulated nodule in the right side, which showed mild uptake on PET later. And I biopsied it, it turned out to be adenocarcinoma. So we picked up thymomas, adenocarcinomas, active tuberculosis, and one patient histoplasmosis. All of these just because CT scans are being done and incidental lesions are being picked up. So these are the modalities that I said I would be talking about. Let's spend a couple of minutes on cardiac MR. Two presentations that I would like to talk about. This patient presented with failure, acute inferior wall infarction, and
please conclude. 2 minutes more.
Yeah, and when we looked at the lungs, we found these areas of ground glass here, which looked like COVID, but we had no experience with MR in the lungs for COVID. And the CT showed COVID, and then the patient was RT-PCR positive. So was the infarct due to COVID? Were the two things coincidental? We don't know. But the other thing we've been finding is COVID myocarditis. So that's a 21-year-old who presented with acute coronary syndrome while she was RT-PCR positive. You see the hypokinesia of the anterior wall on the short axis, a dyskinetic septum. And on our multiparametric, we have edema on the STIR and T2. T1 is normal, which is expected, and the patient has extensive fibrosis. So this patient will have long-term damage. Some of this will improve, but some of this will not. So when we follow up the patient, perhaps after about 3 to 6 months, we'll get a clearer picture of what is happening. So in summary, I've discussed the role of CT in the lungs, and we've talked about everything from the signs to vasculopathy to severity and extent scoring to CORADs. We've looked at incidental findings and some unusual appearances. And then we've looked at the role of MR as far as the heart is concerned. We see about 1 myocarditis a week, not more than that. But nevertheless, these are all issues that are constantly going to keep cropping up as time passes by. I'd again like to thank MMC for the opportunity to give this talk. Thank you so much, everyone, and have a great meeting from now on and tomorrow. All of you delegates who are listening to these wonderful speakers and panelists who are participating. Have a good weekend as well and stay safe.
Thank you, Bhavin. It was actually a very difficult topic. It is difficult to present in 20 minutes or 25 minutes. But sorry, because there are so many speakers and we are already short of time. So it's a wonderful lecture. Thanks again. And I'll give it to Archana, madam.
So very quickly, if anyone has questions and they put it up on the Q&A, I can answer those questions without speaking. So I can hang around and do that. So please feel free to ask questions in the Q&A and I'll take them. Thank you.
Thank you, Dr. Jankaria, for being so understanding. All the participants, if you have any questions for the panelists, please put them on the Q&A box and we'll be happy to take them up. So we move on to our next session. Thank you, Tambe sir. With a wide spectrum of pathological and biochemical investigations available at our disposal, it is imperative that we use the correct investigative modalities in proper settings so as not only to extract maximum out of the investigations, but also to reduce the financial burden on the patient by avoiding unnecessary investigations. So to talk about why, which, and when of pathological investigations in COVID-19, we have with us a speaker par excellence, Dr. Avinash Phadke. To introduce the speaker and chair this session, I invite Honorable Vice President of MMC, Dr. Venki Roghwani. Dr. Roghwani is also a member of Maharashtra State Pharmacy Council, Governing Board member of State Blood Transfusion Council, and Executive Body member of IMA and IAP Nagpur. Over to you, Roghwani, sir.
Thank you, Dr. Archana, and welcome, Dr. Avinash Phadke. We very oftenly see that there are many queries which come in front of us, like which basic panel tests are to be done in mild disease, in moderate disease, in severe disease, and how frequently we should repeat these tests. So such type of queries. To answer this, we have got a very eminent speaker, Dr. Avinash Phadke. He is a president and mentor of SRL Diagnostic. He is governing board member, Prince Ali Khan Hospital. He is trustee and governing board member, Cancare Trust Cancer Hospital. He is advisor to Family Planning Association of India. He is teacher of MD Pathology in Bombay University, recipient of multiple awards. He has participated in many national and international conferences as a speaker. So over to you, Dr. Avinash Phadke ji.
Thank you so much. Let me thank Dr. Archana, Dr. Utture and MMC for giving me this opportunity. I will restrict to my timing and we would focus on very commonly used investigation. But like we said, we wanted to extract maximum information out of it. So what is the clinical relevance of each investigation? What is the timing at which they should be performed? And is there any other interpretation than what we commonly perceive? These are the factors which I would be talking about. Now, you know that COVID RT-PCR testing is the standard test. I just wanted to share with you that each RT-PCR test, essentially what it means is a sample, a nasopharyngeal swab and a throat swab collected in viral transport media. It is followed by a procedure called RNA extraction. Then there is conversion of RNA to DNA in a PCR machine with amplification. And after amplification, certain number of cycles, a signal is generated and a positive test gets picked up after a particular number of cycles. So this is called as a cyclical threshold value or a CT value. Now, we must know that when we are doing a RT-PCR testing, the good test should include at least 3 different genes. So, for example, if you talk about E gene, it is common to all coronavirus species and it is not specific to COVID-19. So you cannot give positive report only on the basis of E gene. But if you have E gene and N gene or E gene and S gene, then you can issue a positive report. Why I am telling you this? Because there are kits in the market who use single gene. Now, currently we all know that there is something called as a double mutation. Now, what is this double mutation? It is happening in the region of spike protein. Now, spike protein, if there are 2 mutations, the antibody neutralizing capacity towards this spike protein may go down. Then the question asked to me is whether the test is capable of picking up this double mutation. The answer is yes, because we are not relying only on spike protein. We are also having E gene, N gene, or ORF or RDRP genes. So that is the importance of using kits which are having at least 3 genes for identification so that you don't miss out mutants, whether it is a British variety, a South African variety, or a local double mutant. Now, all of you have seen that the conventional RT-PCR takes about 12 hours to 18 hours, depending on the workload. So in emergency situations, what we would do? In emergency situation, we have point of care instruments. There are 3 different types. There is something called as a gene expert. There is something called as TrueNat, and there is something called as Abbott instrument, which is at the airport. Gene expert and TrueNat give report within 1.5 to 2 hours and also give CT value, while the Abbott instrument just gives you positive or negative report, but it gives you in 15 minutes time. Now, what is this misconception about CT value? You know, every clinician is asking for CT value and they are saying that a lower CT value, which generally indicates higher viral load, is related to poor outcome. Now, is it the truth? That is not the truth. What a lower CT value indicates at any given time that this person is having a high viral load and is possibly higher infectivity. That means he is capable of infecting others in greater numbers because his viral load is high. You will see many young asymptomatic individuals with high viral load and many individuals who are seriously ill with low viral load. So CT value correlation with clinical outcome is poor. Though, as Dr. Shashank Joshi mentioned, if somebody has extremely higher viral load, it becomes a challenge with comorbidities, and then it will have some value. But by and large, there is a poor correlation between a CT value and clinical outcome. But a good correlation with CT value, lower CT value means higher viral load and higher infectivity. Now, what about the antigen testing? Antigen test, the sensitivity is only 70%, specificity is 90%, should be done in first 5 to 7 days. Now, timing of the test, like Dr. Archana told me to talk about timing. Now, when you time RT-PCR, the ideal time is on 36 hours to 48 hours after the fever onset, not in the first 6 hours or 12 hours or 24 hours. You are likely to get false negative on up to 48 hours to the tune of 30-40%. And you don't want to miss COVID. So ideal time to time a RT-PCR is 48 hours. Now, if the patient comes to you after 7 days and he has done a CT scan with Dr. Bhavin and Dr. Bhavin has reported that it looks suspicious of COVID, but your RT-PCR is negative. Why this type of paradox happens? Because the viral replication is happening in first few days is nasopharynx and throat. Then the virus is migrating to lungs. So if the patient comes to you after 7 days, probably a sputum or a bronchoalveolar fluid is a better specimen than having a nasopharyngeal swab. So this is where the timing plays a role. So antigen test should be done in first 3 to 5 days. I have told you about sensitivity being very low, about 70%. They can miss out a lot of patients with low viral load. So anybody with a CT value above 30, antigen test is likely to miss it. It will report it as negative. And symptomatic negative patient, if they have a negative antigen test, it should always be followed by RT-PCR. This is the ICMR guideline. We have no option but to follow it. When we come to blood tests, Dr. Shashank Joshi rightly pointed out the two most important tests. If you ask me which are the two most important tests in most of the COVID patients, we all talk about fancy tests like IL-6, D-dimer, ferritin, and so many other markers. But the most two important tests are simple blood count and C-reactive protein. These are the star tests. Now, when you do a blood count, lymphopenia, absolute lymphocyte count probably less than 1,000. Now, see in COVID, what is happening? The nuclear NL ratio, what is neutrophil to lymphocyte ratio, is greater than 3.13, but it is probably more towards 5 or 6. There is eosinophilia, low level of platelets, and a raised RDW. Now, here the interesting phenomena of what happens to CD4 and CD8 counts in COVID. Now, we all know our experiences in HIV. In HIV, there is selective depletion of CD4 compared to CD8. So your CD4 to CD8 ratio becomes less than 1. In COVID, CD4 is decreased, CD8 is decreased, the ratio is unchanged because there is absolute decrease of both the parameters as well as the natural killer cells are also decreased. So this is across the board lymphocytic depletion. Now, if you look at asymptomatic patients, lymphopenia is seen only in 15%. In moderate COVID patient, lymphopenia is seen in about 50 to 60%. And in serious COVID patient, lymphopenia will be seen in almost 90% of the patient. So in an asymptomatic COVID positive patient, lymphopenia is not common. It is seen in only 15 to 20% of the patient. Now we come to C-reactive protein. When you ask for C-reactive protein, don't ask for ultra-sensitive C-reactive protein. That is meant for cardiac risk evaluation. The measuring range of ultra-sensitive CRP is up to 20 milligrams per liter. And we in COVID, the CRP value can go in hundreds. So you ask for conventional CRP. Most important parameter in inflammatory marker, the first one to rise and first one to come back. So if you are monitoring a patient, you can't monitor the patient with IL-6, you can't monitor the patient with ferritin to judge the clinical response of your therapy. You have to go strict. ESR is out of question, too late to rise, too late to fall. So the only marker which is of clinical significance in a hospitalized patient or home monitoring situation is CRP. Very rapid response to steroids, a significant drop in CRP value. A persistently high CRP value may indicate a concomitant fungal infection. CRP, as I have mentioned, is the first parameter to come back to normal after the patient has improved. Patient is discharged from the hospital with normal CRP, but high ferritin, high D-dimer, and the treatment of thromboprophylaxis may continue for another 6 weeks. That doesn't mean patient is seriously ill. The other markers take time to come down. CRP will be coming down much earlier compared to any other inflammatory marker. So as I have mentioned, both CRP and ferritin track the disease severity, but CRP is the earliest one to rise or fall. Now we come to procalcitonin, very less talked about marker. Procalcitonin, the normal value is 0 to 500. Now, I think there is a mistake. The normal value of procalcitonin up to nanogram per ml is 500. Now, a normal procalcitonin has a very good negative predictive value for concomitant bacterial infection. So if you have an absolutely normal procalcitonin value, it assures you that this patient has only COVID and no concomitant bacterial or fungal infection. It also differentiates between bacterial and viral. So if it's an uncomplicated COVID, you are expecting your procalcitonin to be normal and not raised. If procalcitonin is raised in COVID patient, you are thinking about concomitant bacterial infections or sepsis. Again, a useful marker for day-to-day monitoring because the half-life is short. So in an ICU patient, sometimes you do it daily, even twice a day, because the half-life is 24 to 36 hours. A low normal PCT in COVID-19 patient has absolutely fantastic negative predictive value for sepsis. You have virtually ruled out sepsis if the value is low normal. Then we come to ferritin. Now we know that the ferritin is raised because it's an acute phase reaction. Pardon? Sorry, did you say anything, Dr. Archana?
No, sir. No, sir. It was somebody had unmuted. Sir.
Okay, sorry. So ferritin is increased in many other chronic conditions like liver diseases, Hodgkin's lymphoma, but it is useful as a marker in inflammatory marker to judge the severity of disease in COVID patient. We have seen values up to 2000 and these patients do poorly. But please remember that once the CRP comes to normal, temperature is normal, oxygen saturation is normal, just because D-dimer and ferritin is elevated, we don't keep the patient in the hospital. Patient can be safely discharged. This will take 3 to 4 weeks to come down. So don't expect your ferritin to come down. Now, interleukin-6 is a very interesting marker and a very useful marker. We know that the normal range is 0 to 7 picogram. It is raised markedly if there is a cytokine storm or if it's a patient with moderate COVID. But if you ask me, you have to be very careful with interleukin-6 values because false high readings are very common. So if you are receiving sample collected outside, coming to lab after 3 hours in a plain red tube, the value can be at least 5 to 7 fold what it should be because of the transportation and delay in processing. So do not accept sample which is not collected in EDTA plasma. So the interleukin-6 values are stable in EDTA for up to 24 hours. If you use plain tube, it has to be analyzed in half an hour to 1 hour. Every passing hours, if I do the same test from a plain tube and serum, if I do the test after 1 hour, the reading is 5. If I do it after 6 hours, the reading could be 60. So you can imagine the magnitude of problem. So please insist on a EDTA plasma for interleukin-6. Now we come to tocilizumab. Now tocilizumab is a monoclonal antibody towards receptors of interleukin-6. So what many clinicians do, that they give IV tocilizumab and follow it up with the interleukin-6 value next day to see whether the patient is responding. It is absolutely irrelevant because the interleukin-6 will not come down. You are blocking. It is like saying if I am giving ARBs, that is angiotensin receptor blockers. So if I am giving telmisartan to the patient, it is blocking the angiotensin 2 receptors. But if I test the angiotensin 2 value in the blood, the angiotensin 2 value is actually higher on patients with ARBs. Similarly, when you are giving tocilizumab, it is blocking interleukin-6 receptors. It is not neutralizing interleukin-6. So the response to tocilizumab is to be monitored with C-reactive protein because this receptor blockade will stop the biological activity of IL-6 without altering the biochemical value. And that response will be predicted by drop in CRP and not in drop with interleukin-6 value. I hope I have made myself very clear on this. Then we come to D-dimer. The normal range is up to 500. Very careful which platform. It is not good on CLIA platform, that is on chemiluminescence biochemistry platform, the values don't come correctly. So you have to use a bioMario platform or a Stago platform or a dead bearing platform. So automated coagulation analyzer or bioMario platforms are the gold standard. Please do not accept reports which are done on conventional biochemistry analyzers for D-dimer. The reports are not very accurate. Now, what is the difference between a fibrinogen degradation product and a D-dimer? Now, fibrinogen degradation products are fairly non-specific. D-dimer refers to only cross-link diffraction of fibrinogen degradation product. So if you are doing D-dimer, there is no need to do simultaneous FDP, because we many a times get requests from the patient, they are testing for serum fibrinogen, D-dimer and FDP. Absolutely unnecessary, just do D-dimer. D-dimer is the earliest marker to rise after thrombotic episode. Values greater than 2000, that is 4 times the value, means you need aggressive thromboprophylaxis, which may continue for a length of time. Patient may require first injectable thromboprophylaxis with low molecular weight heparin subcutaneously. Once the hospital is discharged, he may then be put on oral thromboprophylaxis. Don't expect D-dimer to come to normal before discharge. Don't wait for D-dimer to come to normal. Just like ferritin, if the patient is otherwise clinically stable and CRP is normal, don't wait for these biochemical parameters to come to normal before you discharge your patient. Then, like Dr. Archana has stated, we are dealing with a lot of fungal infection. We all know about mucormycosis, but we are seeing aspergillosis, we are seeing candida infection, we are seeing nocardia, and one of the commonest infection is aspergillosis, and we have a good test for that, an antigen called galactomannan, and the test is done on the blood. And if you are suspecting aspergillosis, this test is fairly specific for aspergillosis, doesn't come positive in a candida infection. But remember, this is not to be used for mucormycosis, it is negative in mucormycosis. The other test in the blood for fungal infection is bleedy-glucan. It is nothing but beta-D-glucan, which is produced by certain species of fungi, mainly Candida, Aspergillus, and Pneumocystis. These three will give high positivity for BD-glucan test, but it will not be raised in mucormycosis and cryptococcal infections. Then we come to the current problem, which is the diagnosis of mucormycosis. Now, mucormycosis diagnosis is also becoming a diagnosis similar to frozen sections. An ENT surgeon from Nasik or Amravati calls me that on table they want to do a KOH preparation to know healthy tissue from the not healthy tissue when they know that their resection is complete. And they send samples for KOH, and their complaint was the KOH report is negative, but the same tissue then is sent for histopathology, and histopathology is reported as positive. So unless your microbiologist is experienced with KOH, you can then use enhancement dyes like calcifluor, where you can then observe the fungus under fluorescent microscope, but KOH is good enough. Standard fungal culture, whether saboroids, potato agar, show good growth, but growth will happen only in 50% of the collected samples of mucor. So suppose you have collected 10 samples of mucor, 8 will show positive KOH, while 5 will show only positive culture. So remember that. So the culture is very specific, but it is less sensitive than a KOH preparation, because KOH is picking up non-viable fungus. The cultures are not going to pick up the non-viable fungus. So the culture identification will take 3 to 5 days. Moment there is growth. Now we have an instrument called as MALDI-TOF, which is a mass spectrometry instrument. It can do fungal species identification. The time taken is only 1 hour to 1.5 hours. So moment our culture is positive, within 1 hour, we are able to tell the clinician that this is particular species of mucor is there. So identification doesn't take time, but we cannot use direct fresh specimen, whether it is ball fluid or a pleural fluid. We cannot directly do MALDI-TOF. We have to first culture it and put on MALDI-TOF. There are protocols underway whether we can directly use fungal specimen from tissues on MALDI-TOF, but as on today, there is no standardization. So if any lab is reporting directly on MALDI-TOF, that is not something which is advisable. The RT-PCR have become available for mucormycosis diagnosis. Now report is available on the same day. The bronchoalveolar fluid, tracheal aspiration, sputum, pleural fluid, or even a paraffin embedded box is an acceptable specimen for diagnosis with PCR. Then I must talk about two panels, that is BioFire respiratory panel, which is essentially, it picks up all the different viral pathogens. So it will pick up coronavirus, influenza, para-influenza, respiratory syncytial virus, and the report is available within 2 hours. It is a methodology called film array, and it is manufactured by a particular company. So it's a closed system, and it's a very vital system for intensivists. So any intensivist will tell you that for his ICU admission patient, for tracheostomy patient, for ventilator patient, he routinely requires a respiratory BioFire, or what is next, a pneumonia BioFire. Now, pneumonia panel is essentially bacterial pathogens, which are Haemophilus influenza, Pseudomonas, Staphylococci, Klebsiella, Chlamydia, Mycoplasma. These are covered with BioFire pneumonia panel. Lastly, I come to COVID antibody testing, because everybody is interested in knowing which antibody test, and too much confusion. Remember the earlier test, whether it is total IgG, IgM, doesn't matter. All earlier generation antibody tests were testing with antigen target of nucleocapsid antigen. So that is an antigen which was tested. So after vaccination, if you want to do earlier generation nucleocapsid antibody test, those tests will come negative after vaccination, because we are generating spike protein antibodies after vaccination and not nucleocapsid antibodies. So post-vaccination, if you want to know your immunity, the test to be done is a spike protein antibody. Spike protein antibody will be positive in previous COVID infections as well as vaccinated patients. The normal value on Roche instrument, anything above 132 is considered as good immunity. Unfortunately, you will have 18 to 20% patient who will show poor antibody response. The maximum level of antibodies, study done by our lab and ICMR in 4,000 patients. What does it show? That patients who had COVID and have received vaccine produce antibody levels which are at least 5-fold than those who did not have COVID and just received vaccine. So those are the lucky ones who had mild COVID and received vaccination. Their immune response in terms of neutralizing antibody is very, very good. Now, when we are talking about spike protein, it is not synonym with neutralizing antibody. Neutralizing antibodies are live wire cultures, and then we are testing neutralizing antibodies. But there is a 86 to 87% correlation between spike protein antibodies and neutralizing antibodies. So we use spike protein antibodies as a surrogate marker to judge the immune response, as if we are testing neutralizing antibodies. Now, when do you do nucleocapsid antibody? That is the earlier generation test. If your interest is only to know whether patient had past exposure to COVID, then patient need not spend money on expensive tests like spike protein antibody. You can just do a total antibody to nucleocapsid, and that will show positive. But don't try to do nucleocapsid antibody post-vaccination, because many doctors make that mistake and the report comes frankly negative, because you are not generating antibodies against nucleocapsid antigen. The vaccine targets are all spike protein. The current vaccination, whether it is Roche, Pfizer, Covishield, all are targeting to generate antibodies against spike protein. Now, if there is a mutation, as it is happening in Indian situation, in S1, S2 region, that is the receptor binding domain of spike protein, then you will see that the efficacy of vaccine, like Dr. Shashank Joshi mentioned, phenomena of vaccine escape, that may happen because the antibodies which are produced by prior vaccination will not be fully effective because the spike protein region has undergone a mutation. Now, how to identify these mutations? There is something called as a next gene sequencer, which can do RNA as well as DNA mutation analysis extensively. You can focus on one single region, say spike protein, and do multiple slices of RNA to know what is the exact level of mutation. And India needs to do more number of next-gen sequencer. There is a instrument which is now available. It's a tabletop instrument.
Excuse me, Dr. Phadke, please sum up. Only 2 minutes.
Yeah, so this is the last sentence. So we need to do more next-gen sequencing to know any mutant strain emerging and resulting in phenomena of viral escape. Thank you for your patient hearing, and I hope the lecture answered most of your questions. And I am thankful to Dr. Archana, MMC, as well as Dr. Utture for giving me this opportunity. And thank you, Dr. Winky, for moderating this session. Thank you so much.
Thank you. Thank you so much, Dr. Avinash. Wonderful presentation. Given in short time, you have done a very nice job, very specific presentation. One question which has come on a chat box is that if there is a thromboprophylaxis has been started after D-dimer, when D-dimer should be repeated? After how many days?
Not earlier than 3 days.
Okay. What about IL-6?
IL-6 and thromboprophylaxis correlation is...
No, not in thromboprophylaxis. Usually, when to repeat IL-6 once it is raised?
No, see, I told you about the situation of tocilizumab. In that, you cannot repeat and expect it to drop down. In otherwise situation, IL-6 is generally done every 48 hours. There is no point in repeating it daily basis. Okay. And as I mentioned to you, EDTA plasma is the gold standard. So don't try to use any other material because it is virtually futile to do the test because you can't interpret that IL-6. One of our task force member had a value of 70 and the repeat with EDTA, the value was 3. So that kind of a difference can come.
Okay. So thank you so much. If you have got any questions, you can put on question answer chat box. And over to Archana. Thank you so much, Dr. Avinash.
Thank you so much. Thank you.
Excellent practical presentation. I'm sure that so many people who are attending from all the corners of Maharashtra, and we have got delegates from all over India also. You have given them really very practical pointers which they should be able to utilize in their day-to-day practice. I now invite Honorable Member Maharashtra Medical Council, Dr. Bakulesh Mehta sir, who is past President IMA Maharashtra State and past President of GPA, to introduce our next session. Over to you, Mehta sir.
Thank you. Thanks, Dr. Archana, for kind words. There is a lot of talk and anticipation about third wave of COVID, a wave which is more likely to affect pediatric population. But are we ready for it? So we move towards our last session of the day, a panel discussion where we discuss anticipating, preparing and tackling of the third wave with our expert panelists. We have our own panel today, Dr. Tatya Rao Lahane sir, Dr. Sadhna Taide, Dr. Sanjay Oak, Dr. Suhas Prabhu, Dr. Shivkumar Utture, Dr. Jayesh Lele. For further proceeding, I will request Dr. Archana Pate to take over, who is a dynamic member of our this COVID force and COVID summit. She has worked very hard for this successful of this COVID, our panel and our summit. Over to Dr. Archana.
Thank you so much, sir. I will, in very short, I will be introducing the galaxy of panelists that we have over here with us today. Our first panelist today is Dr. Tatya Rao Lahane sir. I think sir ke liye we have to say naam hi kafi hai. Sir needs no formal introduction, but I will still do it as a formality. Sir is Director, DMER Mumbai. Sir is Director, Professor, Regional Institute of Ophthalmology. In charge, Cataract Free Maharashtra Program, National Blind Correction Program. Chairman, Authorization Committee, Organ Transplant. President, Maharashtra State Board of Nursing and Paramedical Council. Maharashtra State Nodal Officer for COVID-19, ex-Dean of Grant Medical College and JJ Hospital. Sir has a world record to his name for more than 162,000 cataract surgeries till date and awarded Padma Shri in 2008, the fourth highest civilian award in India. Our next, just give me a minute. Okay, 1 minute. I'm so sorry.
Go ahead. No?
Yeah. So our next panelist today is Dr. Sadhna Taide, madam. Madam is Director Health Services of Maharashtra. During her professional career, she has worked in almost all levels of health department. Currently, since last 2 years, Madam is the Director of Health Services of Maharashtra. She is Director for State Blood Transfusion Council Maharashtra, and she is active member of FOGSI, MOGS, and presented papers in various conferences. Our third speaker for today is Dr. Sanjay Oak, Chairman Maharashtra Task Force Against COVID-19, former Dean BYL Dyer Hospital, Director KEM Hospital, Vice Chancellor for DY Patil University, Mumbai, CEO Prince Ali Khan Hospital, and recipient of BC Roy Award. The next panelist is Dr. Suhas Prabhu, Consultant Pediatrician, PD Hinduja Hospital since 1986, ex-HOD Pediatric Department, KB Bhabha Hospital, member IAPCOI 1112, convener, convener revised PSPID, RAP and WAR modules, co-author of Gems on Childhood TB, APID, AMS, contributed chapters in several books, author of many publications and recipient of multiple laureations, and he is chairperson of the Government of Maharashtra Task Force for tackling third wave of COVID-19 in pediatric population. The next panelist is Dr. Shivkumar Utture, President, Maharashtra Medical Council, Member, National Medical Commission, Member, Medical Advisory Committee, NMC, past President, IMA Mumbai Branch, Executive Committee, Maharashtra Medical Council 11 to 16, retired Professor of Surgery, Grant Medical College, UG and PG teacher, MUHS examiner for 35 years, recipient of multiple Corona Warrior Awards from NGOs and medical associations, Honorary Surgeon St. George's Hospital, Honorary Surgeon Fortis Hospital. And our next speaker for the day is, for the panelist, is Dr. Jayesh Lele, Honorary Secretary General, IMA Headquarters, Executive Member, Maharashtra Medical Council, past Honorary National Secretary, IMA Hospital Board of India, past President, IMA Maharashtra State, recipient of multiple awards and delivered many orations, and member Accreditation Committee and Ethical Committee. So we now move on to our panel discussion. Since Sanjay Oak sir has requested that he may need to leave early, we will be asking us our initial questions to Oak sir. And sir, we start this panel discussion with you. So there is a lot of talk about third wave. Can you please tell us, when do we expect the third wave? Is it inevitable?
Thanks, Archana, for giving me an opportunity. And right at the outset, I congratulate Maharashtra Medical Council for a fantastic presentation. Yes, you asked me if it is inevitable. If we study what is happening in the world, since this is a pandemic, we see ramifications and reflections of this disease globally in different parts, in different phases of the disease. What is a wave? Wave is a period of surge followed by a lull. That means the cases would increase and then the cases would decrease. So it's a classical parabola design. And if we analyze this parabola, then we get some indicators out of it. The rate of steep ascent, then the phase of plateau, and the rate of decline. Where do we stand today? Today, as we heard our Honorable CM quoting right from the figures, if we take the state of Maharashtra, we are somewhere near our plateau or a little below that. But all districts are not the same. In fact, 22 districts are still having very high prevalence. Our mega cities have started showing better results, but they are not the same, as you will also hear from Dr. Lahane a little later. So you ask me, is the third wave inevitable? Yes, Archana, some scientists feel it is inevitable. It is the life cycle of that virus through which we are all going. Are there any mathematical models? There is a mathematical model. In fact, there are several mathematical models. And there is one which came from North Indian universities. This is called as Sutra model, S-U-T-R-A. It's an acronym. And it says that the third wave in India is about 6 to 8 months away. In fact, the predictions were that by the end of May, we will see the second wave declining by the end of May and beginning of June. But the way we have seen the crescendo, decrescendo of the cases, now we feel that we may have first week of July for this second wave to completely settle down. Then there will be a period of lull for a few months, and we may expect the next third wave to come 6 months later, that is somewhere in the fall by the end of this year. The next question that immediately comes is, sir, will it be very bad? What kind of patients it will be affecting? There are again two opinions on that. There are some people feel that many more will get affected. The age of affection will reduce and therefore we will have pediatric population. But there is a second view that says that the third wave will have a cushioned impact. It will be localized in some regions. And the main reason for that will be by then, as a country, we would have advanced in the program of vaccination. So that is where, Dr. Archana, we stand. It's a phase of uncertainty. But I always say, let's prepare for the worst so that we can have the best.
Thank you so much, sir. Basically, we need to understand that, yes, what are these waves that we are talking about, because there is a lot of talk about it in the papers, and it is difficult for the population to understand what waves are we talking about when we talk about this. So there was another query in press about the role of influenza vaccine in the upcoming third wave. Sir, could you please elaborate on that?
Yes, very good you asked me this. I'm sure my other colleague and brother, Dr. Suhas Prabhu, would also elaborate on this. See, none of us, neither me nor Suhas or IP, has ever said that influenza vaccine is a vaccine for COVID. No. Influenza vaccine is a specific flu vaccine. It is not intended for corona. But what will happen is that now with monsoons approaching, with the change of season, we always get several flu cases coming to the hospital. If influenza vaccine is given, it will help to control the flu cases. It will help in the reduction of hospital admissions and unnecessary RT-PCR test. There's a beautiful article that I want to quote here. Incidentally, this was also shared to me by Dr. Prabhu, and I must give him this credit. This comes from a study of University of Michigan. It is published in American Journal of Infectious Diseases. And this article very clearly relates the influence of influenza vaccine on COVID-19 patients. And it says that it reduces the COVID-19 susceptibility. It reduces mortality, ICU care need, and hospitalization. So mind you, the article doesn't say, let's not carry a wrong message that influenza vaccine is going to avoid COVID. No. All that it is saying that it controls the morbidity and perhaps the mortality associated with that. It has also explained its mechanism, and it says there is a mechanism of what is called as trained immunity. Adaptive immune response given by the T helper cells in our body to produce a humoral response and a cellular response when the COVID hits. So the article ends by giving a message that unless and until the COVID-19 vaccine becomes widely available, because that seems to be the final answer, the influenza vaccine can be promoted. And that's why we have been saying that let us complete the regular immunization protocol of children and patients.
Yes, thank you so much, sir, for that explanation. I think that clears out a lot of doubts regarding what we read in the papers. I come to you, Taide madam. Though we anticipate that, madam, you'll have to unmute yourself. Yes, madam. So though we anticipate that this third wave may be, say, about a few months away from now, but though we have ramped up our facilities for the adult population mainly to, accommodate the kind of surge that we have seen in the first wave and the second wave, what is being anticipated is that there are going to be a lot of pediatric cases in the third wave. And we do not have large number of pediatric setups in small towns and rural areas. So can you just give us some information regarding what can be done regarding ramping up of these facilities, as regards to the third wave which is anticipated?
Yeah. Thank you, Archana. And at the outset, let me thank Dr. Utture and his team and congratulate him for such a wonderful COVID-19 summit. Thank you. You asked me, really, it's a fact that we do not have a large setup of pediatric setup at town and at village level, or at village level, or in the rural area. Not even in the private setup also. Definitely. So as Dr. Oak has very well explained that, he said that there is no typical characteristics of this third wave. Not a single person is saying confirmly that the pediatric population will involve. Definitely they will involve. So considering this, whatever the experts' opinion are there, we are ramping up our institutions for accommodation of adult as well as the pediatric age group. So we are preparing for that. The second thing is that as there is a task force at state level, the similar way we have a task force at district level also. And with the help of them, we are trying to develop, we are planning to develop some road ahead and planning for developing our institutions as well as the private institutions which are available at the district level. We are preparing to train the pediatricians whosoever is available in the government. We are giving them refresher trainings. At the same time, the general practitioners, those who are available with us as well as in the private, we are trying to train them. And definitely the state task force will help us in developing all these guidelines. So that is one thing. The second thing is that we do have a district hospitals as well as the women hospital in the district, and we do have SNCU, but as such we do not have pediatric ICUs available. And definitely we'll have these district COVID centers are there, dedicated COVID centers are there, which we have developed during the first wave and the second wave, and 10% of the beds which are available at this DCH will definitely keep for pediatric patients. So this is the way we are preparing for the third wave.
Thank you so much, madam. I come to you, Lane sir. Each wave requires a lot of manpower. So how can facilities at the medical colleges be made more suitable to tackle the kind of patient inflow that is expected again when the third wave strikes? Also, the medical students and junior doctors who are working in this pandemic since its onset, how can we best take care of their safety and well-being, sir?
Thank you, Archana. I think it was a very good seminar, and thank you to all the team MMC. The manpower and this from 1 year we are tackling this issue, and you might be knowing when the first wave came. That time we requested through you only for the practitioners, and we asked them that those who are less than 45 years of age, no comorbidity, they can join. and near about 4,600 people they joined and they worked there. Secondly, we also asked the people who are the resident doctor passed their examination, the bonded candidate, that is near about 2,500 people. The same thing, we are the third year nurses and also the third year students, they were also trained. And to begin with, you will see the training was there every day. So we were training these people every day. And in the few months, it means first 2-3 months, they were infecting more, contracting more infection. But gradually later on, they understood how to go ahead, and gradually the infection was reduced. But the manpower is again an issue always, because in the we will have to provide the manpower to the health department area also. So we have provided all the students who are diploma holder and also the uh, in the medicine people to the rural area also. Secondly, the this manpower collection, I think we are making it from those people who were just past 5 years before and they have not done the bond. So all these bonded candidates who have asked that they should join, and now I think 2,100 people they have applied and they will join now. Up till now, 954 people have joined already. So another thing comes is the training. See what happens, the people working in the ICU and these are not trained up much up about the ventilator. So this ventilatory training we have done to each and every medical college, that may be online or that may be by a person, expert person, that is intensivist going in that medical college and teaching. So the training in the form of the labs, you can see we have started, there were 3 laboratories and now there are 226 laboratories in the government and private, and also another laboratories of the RAT. So all these people, they were also trained in the laboratories. All the laboratories were notified in the ICMR, registration went done, and every day near about were just adding 1, 2, 3 laboratories, so that today we can do near about 250,000 tests in Maharashtra about this. And all the manpower, it is not only the manpower of microbiology, but we are using the pathology, we are using all the technicians. And other thing what we have done is we have classified the manpower, that who can do what services. And so the paraclinical people and non-clinical people are also where taken into the mainstream. And those people, they were also given the different types of duty where there is no ICU, or the directly they were not doing this treatment in the ICU. Other treatment they were doing. So also the fever clinics. So important thing is in the fever clinic also, we have also asked the other people. That means one person of medicine may be there, but other doctors are helping us. And so all that manpower was collected together. So manpower, I think it is a really big issue. And after that also we could provide the manpower. We have asked the private medical colleges also, they also came forward, and private medical colleges also helped us. So all people who are the doctors, they be in the private practices, private medical colleges, government medical colleges, corporation medical colleges, third year student, third year nurses, interns, all the interns, then the past students, all the residents, and all these people together. I think this was a very big, we can say, whatever the problem of this manpower. And I think we could not, I will not say that 100% it was solved, but every time they ask us ki our pay should be increased, so we increase some pay, given some incentives of 300 rupees. So by all means, I think the manpower has gathered, and that definitely helped us for first wave and also the second wave.
Thank you so much, sir. Dr. Prabhu, I come to you. Pediatrics in itself is a specialty. It's like majority of the practitioners, they are not, they may be doing some, practice at their local level regarding when it comes to pediatrics. But now when we talk about an entire third wave, which may involve a pediatric population, it is like, how do we brace ourselves? What preparations do you think are needed?
Thank you, Dr. Archana, for inviting me. And I must say, as many have said, that I've really enjoyed all the lucid and informative talks that have happened before this particular panel. But I'll come back to your question. I would like to answer it in its entirety. Dr. Oak has just mentioned that we might get a third wave in children. Maybe it's 2-3 months from now. We cannot say what will be the height of that wave or the intensity of that wave and how much children will be affected. If we have to address this issue, there are only two ways we can do it. One is, can we prevent this wave from coming? Can we prevent? Yes, let's look at what we can do to prevent the height of the wave or the intensity of the wave. Now, as Dr. Oak has already mentioned, the answer to corona is the corona vaccine. But as of now, the vaccine is not recommended for children below the age of 18. So one thing is going on, that there are trials going on in children between 12 and 18. There are trials going on. Once the answer comes that, one way to solve this problem is to make sure that the children are immunized. The second thing you can do is, as Dr. Oak has already mentioned, that there is some kind of interaction or immune stimulation that is happening with vaccines. One of them is influenza vaccine. There have been studies on the MMR vaccine. And of course, there is a trial going on the RBCG vaccine, where we can do a general immunostimulation, which can prevent the child from becoming very sick from COVID. Remember, it does not prevent corona infection. It prevents the severity of the COVID disease. So that's what can be done. So this is what we can do for prevention. But what else we can do for prevention? Remember, our standard preventive measures should not be stopped. That is our plain SMS. Sanitization, mask, and social distancing. Remember, what is happening is that it's mainly the adults who are going to infect the children, because they are the ones who are currently going out. So adult immunization to some extent will help to prevent the children from getting it. But there is one problem here. For a year, the schools have been closed. There is going to be a situation now when we have to decide sooner or later that schools will be open. Now, if schools are going to get opened, then of course children are going to start mixing and they can become super spreaders. So schools will have to be equipped. The teachers will have to be told. There have to be screening at the school gate. Children with fever, children with history of COVID in the family will have to be excluded. Teachers will have to be trained to identify a child who looks unwell, who shows signs of COVID, who can be detected and referred in time. So this is what we can do as far as the prevention is concerned. Now, coming to the point, suppose we actually get patient. What do we actually need to tackle a wave of high number of cases in children? We need essentially three things, and I'm going to talk about each of these in detail. First is you need facilities. Fortunately, in children, over 90 to 95% can be managed at home. But yes, there is about 5% or maybe a little larger percent who are going to need some kind of facility. And there are two types of facility that might be needed. One is the second level tertiary care, where you just need oxygen and some bed, like a COVID care center, like the DCH that you have. And of course, a small percentage of patients will need ICU care because of severe COVID and its complication. So we need to ensure that we have enough of these facilities. Now, it's very difficult to set up a new intensive care unit. So what we have to do is to identify the intensive care units that are already there, the pediatric intensive care units. We have already initiated, the task force for pediatric has already initiated. Dr. Lahane was there in the meeting that we had on Monday, that we are going to identify, both in the private and public sector, every single PICU bed or HDU bed that is available, tally them across different districts, see where the deficiencies are. And Dr. Lahane has already promised that at least in the medical colleges, the number of beds is going to try and double so that we'll have enough facilities bed-wise. Then we're also going to look at the equipment, the number of ventilators required, 2D echo machines required, very important drugs. In children, we don't need so much favipiravir, of course, we don't use remdesivir, we hardly use, but we might need for the MISC variety, a drug that is IVIG. So we need adequate stocks of this, and that the government will provide for that. And of course, methylprednisolone injection will be required, adequate stocks will be maintained. So this is about the equipment and the facility. But Nothing will happen without doctors. I think Dr. Larne has gone into length about telling us how we are ensuring that there are enough doctors. Our task force is in the process of instructing all these doctors on how to tackle COVID. We know that under the Honorable Chief Minister's guidance, we had one big YouTube webinar last Sunday, and I am told there were 6,300 doctors all over the state who attended, but we are not stopping at that. Message has gone out to every district, and there will be regional webinars happening, which essentially this message will be repeated so that every pediatrician, Maza doctor, as Sahib said earlier today, will be knowing what to look at when he sees the COVID, how to diagnose and how to treat. There are 4 webinars scheduled in a row starting from 1st June, 2nd, 3rd and 4th in 4 regions. One webinar already happened in Navi Mumbai, and there are going to happen several such webinars under the direction of this pediatric task force. The third is that besides this, we are going to need many more people. In the rural areas, the doctor is far away. Yes, there is a Maza doctor, but sometimes he is 30 kilometers away. So who is the person of first contact who can help the parent deal with the COVID, identify and do the home monitoring? And these are our paramedical workers. I think you know that in our state, we have lakhs of Anganwadi workers, what are called Asha Tais, who will be familiar going home to home. They need to be trained. We are in the process of making a module that will be broadcast on the 6th of June. Again, Uddhav Sahib is going to be there, and we hope to reach out to train all these people. Lastly, we also need to inform each and every citizen of this state that COVID is nothing to be feared. What is more dangerous than the third wave is the fear of third wave. Just imagine if every mother whose child starts sneezing or gets fever thinks that my child has got COVID and starts running to the COVID center, there will be panic and we will not be able to manage. So we need to inform every citizen that what is COVID, majority of cases it's mild, and when to seek help. So all this we are doing as part of the third wave task force. Thank you.
Thank you so much, sir. I come to you, Utture, sir. I'm sorry. Yeah. I come to you, Utture, sir. Our private practitioners have been working incessantly for last 1 year, I think round the clock. But I think their role is going to continue and it may even increase. So as President of Maharashtra Medical Council, what is your advice to our members, our registered medical practitioners?
Yeah, thank you, Dr. Archana. See, basically, it's a twofold thing that as far as MMC is concerned, we are looking at it. And that is what we have been doing. The first is that the dissemination of the information which was there. As you remember, last April, we were absolutely not knowing what we are tackling, what we are dealing with, because this was a new disease which was there. And none of us had heard about this disease or read about this disease before that. So the first function as far as Maharashtra Medical Council was concerned was getting to all our members all the details which ICMR or the Ministry of Health and Family Welfare put forward, or the task force which was there right from day one in Maharashtra, they put forward. And that is the information that we have been disseminating right from last year itself. And I think what today's summit is also part and parcel of dissemination of that information. And today's summit, as you know, that there have been a lot of talks on COVID, but it has been individual, either pediatricians talking or gynecologists talking or physicians talking. But what we try to do is today and tomorrow to bring everybody under one umbrella. And not only bring everybody under one umbrella, but we wanted the authentic people who are actually dealing with COVID to come out and tell us how are we supposed to tackle this disease. And that is the importance, because as I said, we do not know what this disease is. So it is only by experience of these doctors who have been dealing with the COVID that we are going to learn how to do that. And that has been the main aim. As you know, basically registration and of course ethics these are the two main functions of the council. But the Maharashtra Medical Council, as usual, we have a very dynamic body and we think far ahead of that. And we have forayed into the realm of teaching also now. And that is what we are going to do. So we have got our own platform also, where again today whatever we have, whatever lectures we have got, tomorrow what we are going to have is going to put on this platform. Everything will be put, so that even those who have missed out or those who want to go back and hear these experts, their opinion and their management of these patients, they can go back to this platform and hear the whole thing. So that is what basically Maharashtra Medical Council is doing as far as the private practitioners are concerned. Of course, we have also taken care to see that we spread the word around that all private practitioners, when they are dealing with these patients or in their private practice, because as you know, more than 80% of these patients are asymptomatic. So we have also been disseminating knowledge to them, how they should take care of themselves and protect themselves, because as all the speakers before me have said, the health sector workers and the doctors are a very, very precious commodity. And as you know, we are losing doctors left, right, and center. Almost every day we are getting the bad news that we are losing someone. And these doctors cannot be replaced. So that is another thing that the Maharashtra Medical Council has been doing. Thank you.
Thank you so much, sir. Yes, we need to look after our medical fraternity as much as they look after the patients. Dr. Lele, you represent Indian Medical Association. You are the Secretary General representing the largest NGO of medical practitioners. What is your message to the doctors? If the third wave is expected to be affecting more of the children, can adults be lax?
Thank you, Dr. Archana. Let me congratulate the entire team led by Dr. Utture and all speakers. I was listening the 4 speakers, Dr. Avinash and Dr. Shashank and others. It's a very good, very informative, and definitely it is going to be a CME platform will be good for our doctors. As regards your questions, definitely the adults cannot be lax, because it is not just that they are saying that the third wave, see, the lot of unpredictable things are going to occur. That's what everybody is talking about. Adults, definitely adults, the possibility is that many will be vaccinated, because suppose, as it was mentioned, 4 to 5 months. So let us have the good amount of vaccination being done in those 4 months. And of course, the vaccination depending upon the government making it available. Some foreign vaccinations entering into the Indian market, and then if the vaccination is there. But yes, definitely we cannot lax in laxing that adults should be just because they have taken vaccine. We know today also we have seen that many our doctors who have taken vaccination, but still they suffered the COVID disease. Of course, they might have suffered very mild, but then yes, they have suffered. Even our patients and those doctors or adults who have not completed the second dose, because now the government has said that you take the second dose after 3 months and like that. So suppose they don't complete both the doses, there are chances that they may be caught in between. So the chances of laxity is out of question. Basic COVID issues, that sanitization, masking, social distancing, and just as everybody says, don't go out anywhere unless you are really required. Even if there is no lockout, you yourself put lockout onto you and see that you are comfortable and the family is comfortable. Why I'm saying is that because suppose you are saying that the children are affecting more, naturally the family will be affected. Who will take care of the children? All children may not be admitted into the hospital. The children will be in the house, and definitely the people, the parents taking care of the children will get affected. So we definitely cannot say that adults will be at the lax and we should just forget it. So I think they should be equally careful the way they are at this moment of time. Thank you.
Yes, thank you so much, sir. I think from your talk, we gather that vaccine cannot prevent infection. It can only lessen the severity of the infection. And we have to adapt to the new norms and make it as, our normal new norms. I come back to you, Dr. Prabhu. What is your advice to the treating doctors when they treat children? what advice are the doctors expected to give to the parents as far as the warning symptoms are concerned? Because as we know, the symptomatology in children can differ from what we see in adults.
Yeah, a very important point, Dr. Archana. And as Dr. Lele just mentioned, the person of first contact, the MASA doctor, may not necessarily be a pediatrician, can be the family practitioner. So they need to know what to do when they are faced with a child with fever. So I would put it in 3 steps, because we are going to see this third wave possibly a couple of months from now, when there will be a lot of other febrile illnesses because of the monsoon. Dr. Oak already mentioned about influenza, we might see malaria, leptospirosis, dengue, and so on. So when the child comes to the doctor for fever, he may not be a pediatrician. So the first step the doctor has to do is it COVID or not? Is the first question. And very important is the high index of suspicion. That he must think, that thought must come to his mind is, am I dealing with COVID? And ask questions to ensure that or not. Now, I'm not going to go into the details because I think tomorrow there is a full lecture by Dr. Parekh who's going to talk about pediatric COVID. But the step number 1 is to identify the COVID and do the necessary tests. That's step 1. Step 2 is, if you think it is COVID, you do triage. Is this a mild COVID? And I said over 90% are mild, in which case the child can be managed at home. And then I will come to what that needs to be done. But if it is moderate COVID, the child will have to be sent to a COVID care center. And just in case he presents directly in a severe COVID, maybe in shock or maybe like an MISC, then that child will have to be directly sent to a PICU. So this is a responsibility of that doctor to do this triage. And lastly, coming to the point about what to do if the child is sent back home, 2 things have to be done. One is the parents who are at home need to be told what to monitor at home. See, the child may be mild case now, but he may deteriorate after a day or 2. And the parents need to know what to look out for, what to monitor at home. Several things we all know, I think all doctors in this, you need to watch out for the temperature, you need to watch out the saturation, you need to look at the respiratory rate, the intake output, the presence of dehydrations, and so on. But besides that, children have an unusual presentation of what we call MISC, multi-system inflammatory syndrome of children, which is a kind of an immune reaction that you see due to the antibodies against this COVID or coronavirus. And some of these symptoms are little unusual. So if I have to list the red flag signs, which every parent should be told when they're doing home care, is A, look at the vitals. Is the temperature going on for more than 4 days? More than 3 days? That is 1. Secondly, is the saturation dropping just like in adults? They should be monitoring pulse oximetry at home. Third, look at the urine output. Is the child not passing urine properly at all? Fourth, the respiratory rate. Is the child looking breathless, not able to feed? Fifth, is the child very listless, lethargic? We know in some cases it can even have CNS involvement. Some children actually throw a convulsion. So this is the other danger. And the danger signs of MISC are unusual symptoms that you see, like rashes, urticaria, red lips, redness of the eyes, or activation of the BCG scar. These are the red flag signs that the parents have to be told when they have to report to the doctor immediately. Thank you.
Yes, thank you so much, sir. I think that is very important, and whether the third wave involves pediatric population or no, but I think this is something which each and everyone who's seeing a pediatric patient must remember and follow in their day-to-day practice. Lahane sir, I come to you. We are seeing, rainy season is coming in a short while. Do we expect this to have any impact on the number of COVID patients, and are there any specific instructions for medical practitioners?
Ma'am, when the rainy season is coming nearby, we always take the camps in the rainy season. That is a fever camps. So those are very famous camp. All over we organize those fever camp. And now for the practitioners here, we'll have to advise them that this time fever means you will have to also think the COVID. So without COVID, you cannot think the fever. So in the differential diagnosis, now all other fever, that may be a dengue, that may be a malaria, whatever. First diagnosis is a COVID, and then the other diagnosis. So we'll have to classify that this is not COVID or this is COVID, so that we can. So for that we are doing the training of the doctors, and this training also for the camps. So camps will be organized everywhere, and we will also do the test for that. And the test now, the new tests are coming. That is from the person himself can do it from the nasal cavity. That test or the rat will be done, and then we will classify this type of the fever. Definitely in the rainy season, we are going to get more fever patients, and then everybody will worry that the number is coming, though that is a COVID or non-COVID. But I think we are now reducing down. Number of the COVID patients are coming down, so we should not worry more, but we should be ready for everything.
Thank you so much, sir. So yes, COVID will have to top the list of differential that we have in the fever in this rainy season. Taide madam, I come to you. We want from you, do you have any suggestions to the hospitals regarding the incoming rainy season in view of this ongoing COVID pandemic?
Madam, in rural area and in public health department, at the start of raining season or during this time, we start our malaria survey usually. But now, as Dr. Lahane has already said that definitely this year, along with malaria survey, there will be a COVID survey. So all the guidelines, everything will be issued to these MPWs and everything, and they do these malaria survey. They see the water content zones, everything during this season. Means at the start of rainy season. So these all guidelines will be given to them, and definitely will do this survey also, because as Dr. Prabhu has already said that there will be a fewer, that is the most important characteristics in this COVID, and we all know that. So definitely we'll survey for that.
Thank you so much, madam. So let us all behave responsibly and try to reduce the incidence of COVID with the upcoming rainy season, so that we do not have a lot of cases coming in together with all the infections together. I come to you, Utture sir. I want to ask the role of MMC throughout this COVID pandemic. How can MMC assist the medical practitioners? What has been the role of MMC?
Yeah, basically, last year itself, we understood that this was not a very easy disease to conquer. And like everybody has been saying, that the main problem is going to be about the manpower, as far as the manpower is concerned. And we have been working on this from the last couple of years in MMC. And today, MMC, let me say, we are more than 95%. We have gone paperless. Everything is online. And when I say that, the majority of this online work is the registration process, which is there, of both the students who have passed MBBS and want to do internship, and those who have finished the internship and want to go for their future practice or their for bond purpose. Now, if you know, before this, MMC used to take minimum 3 to 6 months to get this registration process done. And for almost that many months, this was an idle manpower which was there. So after we have converted to everything online, let me tell you, today almost you can get your registration certificate done in less than 15 days as far as MMC is concerned, because everything has been done online. We have stopped the process of actual students coming over here to show their certificates, and physical verification of certificates can be done by the deans in their own college and send us the details, can be done by the MMC members who are there in that particular area and can send it to us. So what we have achieved, let me tell you, in this last 1 year, if you see the statistics, that almost 8,500 provisional certificates we have granted for people to do internship, and 12,500 permanent certification we have done. So this has augmented the basic manpower of the doctors, which everybody is talking about. We are, feeling short everywhere, and this has and we have been working continuously with the government. As you know, last time, right in the beginning of the first wave itself, Dr. Lhane sir had requested us at MMC level to go to our members and try to get them to volunteer. And as he has already told you, thousands of our members volunteered for that. We have done that also. Another thing that we have done in MMC is that we were the first council in all of India to legally allow telemedicine to come into play. As you know, before that, there were court cases which were not allowing that. We understood that during this COVID times, it is going to be impossible for the patients to come to the doctors. So as a state council, we allowed in the state of Maharashtra for our members to do telephonic consultation with all our members. Even before the National Medical Commission came out with the teleconsultation documents. So we have allowed that so that, patients, especially elderly patients who did not want to come out from the house and they have these chronic problems, it would be very easy for them to contact the doctors, and the doctors would also keep in touch with these patients for a long time. At the same time, of course, as MMC, we have also been taking care of some of the grievances of the interns and the the resident doctors and everything. And many a times we have the intermediaries we have found between them, and of course we have to thank both Dr. Lhane and Dr. Taide madam also. They have always been quite receptive to whatever we have suggestions we have been giving them from the side of the students. And that has kept the morale of these resident. As you know, these resident doctors and interns are the biggest force as far as tackling this COVID is concerned. They are the ones who have been absolutely on the, when you say frontline, they are the true frontline healthcare workers who are there even before all of us seniors. And keeping them happy and in a good mood so that they can do this work was one of the prime duties of the Maharashtra Medical Council. So during this whole COVID era, the silver lining, I would say, as far as the council is concerned, is we have got out of a cocooning of doing only registrations and hearing ethical cases, and beyond that, we have gone into the realm of being a teaching platform for all our members, disseminating information from the government to our members, and then of course taking care of all the registered practitioners who are registered under the MMC. So this is what we have tried to achieve. I don't know if we have really been fully successful or not, but I hope that we have contributed as far as MMC is concerned towards all these things. Thank you.
Yes, thank you so much, sir. Kudos and God bless to our medical students and the resident doctors who have been our true workforce. To Taide madam, madam, what is the government perspective for below 18 COVID vaccination as the demand is now increasing?
Yeah. We all know that COVID vaccination is an important pillar for in preparedness of this pandemic, COVID pandemic. And but it is not the only pillar. I will say that, as Dr. Prabhu has already mentioned, that the COVID, and Dr. Lele also, that the COVID appropriate behavior is very important. Because if we have this COVID appropriate behavior, then definitely we can decrease the intensity of this COVID wave. So that is important. Regarding this below 18 years vaccination, still the trials are going on. And we do not, as a government, we do not have any guidelines or anything in hand. And therefore, definitely, once the guidelines will come, once the trials are over, everything is ready, then government will prepare for this vaccination also. And right now, we are concentrating on the 45 and above vaccination. And definitely within 15-20 days, we'll start this 18 to 44 also. That is also we are planning now. But let's see. That depends totally on the stock of COVID vaccine. And below 18 is also depending on the trials. Whatever the outcome come from these trials, then we'll prepare for that also. But
Thank
the
you so
COVID
much.
appropriate behavior is very, very important, and without that, we can't do anything.
Yes, madam, you said it so very correctly. Trials is a slow process, and we really hope that we have favorable outcomes at these trials. But there is no alternative to COVID appropriate behavior. I come to you, Lele sir, as through Indian Medical Association, is there something which is representative of the private practitioners that you would like to request to the government on behalf of the private practitioners?
Yeah, thank you. Very important it is. See, basically what is going to occur, third wave, I mean, I'm talking of the third wave, between the second wave and the third wave, we have some time. That time we should utilize to give training to the doctors. And as Dr. Utture sir mentioned about the telemedicine, MMC has approved. But see, I'm talking on the India level, national, just to give you information. Sorry. Niti Aayog and this has already approved, and the NMC also the telemedicine. But there were some small issues because some of the other councils little coordination was required. So we have had two meetings with directly with Niti Aayog. They are going to give the software, and the entire patients who can be managed in the house, not only COVID, but what is happening is non-COVID patients are suffering, especially diabetes, blood pressure, because they are not going to coming to the clinic. In the family physician's clinic, they are scared of entering, and other clinics also many times they are running at a little shorter intervals. So I would request again to the government that the more training can be given, and if possible, the oxygen cylinders can be given very easily to the home management or quarantine or isolation patients in the home, so that they patients can be managed very well by the family physicians on a telephonic consultation, and the strain on the beds availability will be definitely less, and the availability of the those patients who can be shifted whenever they are needed directly to the hospitals can be done. That is one portion. And at the same time, I would request the government one portion that these doctors in the family practice, last year on the similar grounds, many doctors had kept the clinic closed, but subsequently the clinics they opened, and we found that in the first phase of those 748 doctors who expired till December 2020, half of them were the family physicians, and so they were not compensated at all. So I would request the government and Dr. Lahane sir and Dr. Taide and of course Dr. Utture is aware of this situation. So if any government officials can help us, at least they can be insured some for to certain extent for this kind of activity. Because those working in a level 1, level 2, they are insured. But these family physicians who are working, they are not insured. So something can be done by the government, then it will be very helpful. That is what my suggestion is. Thank you.
Thank you so much, sir. Lahane sir, sir is on phone. Yes, sir. Can I come to you? I have got two questions, sir. One is the period of vaccination for Covishield has been increased to 84 days minimum. So I wanted your inputs on this. That is one aspect of the question. And the second is cases of mucormycosis are also increasing. What advice would you like to give from your end to the doctors and to the patients?
The first question I will answer. Archana, in that the Covishield, which we were having the second dose, that is after the 4th week, that around the 6 weeks, later on the 8 weeks, and now we are saying it should be 84 days. See how this is done, because the the antibodies after giving the Covishield, now that is remaining in the body up to the 3 months, and if it is remaining in the body, that is for 16 to 18 weeks. And because of that, now the second dose of Covishield is now advocated after 84 days. So it has got two things. One is when your immunity is there, so here you are protected by the first dose up to 86 days. And if you take your second dose in the 6 weeks, so the longevity of the protection will be 8 months. But if you take it after 3 months, your longevity will be 11 months. It means the longevity of the protection is increased by distancing the booster dose, and because of that it is made practically after trial 86 days. Now the other thing what you asked me about this mucormycosis. See, mucormycosis, in the first wave we were giving steroids, patients were diabetic. After that also we have not seen the mucormycosis. It means what? The first was also the COVID. After that also mucormycosis cases were not seen. Second, it means that the mutant virus is affecting the beta cells of the pancreas. And because of affecting the beta cells of the pancreas, insulin is not secreted more. And because of that, the virus itself is there, increasing the sugar. Secondly, non-controlled diabetes, ketoacidosis, the diseases like the chronic liver, renal failure, kidney transplant, the patients on the you can say some immunosuppression drug, all this. But those patients who are there longer than 10 days in the ICU or in the oxygen bed, in such cases, it is happening 10% happening in the second week of the admission only in the hospital. And when they are discharged, after that, it is happening up to the, you can say 8 weeks near about. Now, patients, as you know, we are ophthalmologists, so the patients are first coming to ophthalmology because they are having the symptoms and signs of ophthalmology. That is, they are having the pain, then the swelling around the eye, and patients are coming. So now what we have done is patients, when they are discharged only, at that time we are doing nasal endoscopy so that we can catch it early. And when patients are discharged, those patients who are prone for getting such type of contract the infection, they have been told everything and they are followed up weekly. And we have made and post this OPD for the mucormycosis. In that, not only ophthalmologist, the dental surgeon, the ENT surgeon, and then the anesthetist, then also the neurosurgeon, physician, all these together they are sitting, examining. Such patients are also, they are phoning each and every day so that if the symptoms are there, they can call back. And so early diagnosis, early treatment, and surgery also, we were doing 1 or 2 surgery every day. But now from the 8-10 days, I have given the instruction to every anesthetist. What happens in anesthesia, they were doing ki iska spirometry karo, iska echo karo. See, spirometry is not going to be normal because lung is already affected. And so we are going to take a consent, that is whatever, that may be, you can say very serious like that, but we'll have to operate the patient. And today I will tell you the backlog in the all government medical colleges, backlog is reduced. Today, patient to be operated in all the 20 medical colleges is less, not more than 40. And we are also now taking the help of private medical colleges, also the deemed university, all these people together. Now we are treating the COVID and this, mucormycosis. And mucormycosis is also made it is included in the Mahatma Phule Jan Arogya Yojana. And under that, 131 hospitals are identified. Because see what happens, we require a team of the doctors. And in those hospitals, there is a team of the doctor, they are registered. But yes, we are open, we can register more. So if they are there having all facilities. And I think we want to prevent it. And how to prevent also, we are giving them guidelines because see, even the cleaning the water, there we are using for the oxygenation. We are asking go for the distilled water, clean the tubes because whenever patient is coming, change the water. So wherever the sources are there, these sources we are tackling. Also the, you can say in the hospital should be kept clean, ICU should be kept clean. And while patient is going home, he should be given all the instructions to protect himself from the mucormycosis. That we are doing. The amphotericin B, I think now it is available and that is now distributed through the collector and the civil surgeon. And now the patients are also getting the amphotericin B. But here we want that all the physicians who are there, if they come across such patient, immediately they should refer the patient, and if they can treat, they should treat the patient. But early treatment, early diagnosis, early surgery when required. It is not that every patient is required surgery. But here I want to give one word of caution that eyeballs are removed in so many patients that is not required. So we have already given the guidelines when to touch the eyeball. And if it is not required, we should not remove the eyeball. And if the eyeball is blind also, but that cosmetically it is good. When you do the exentration, I think it is very difficult to you can say implant the cosmetic eye also. And I think the number will get definitely reduced as the prevention is also there. And I have already instructed. And also I want to instruct all the people who are attending this, please don't give the steroid when it is not required from first day. And it is already said that the steroid are not given for first day because that is a first 7 days because that is a stage of viremia. And so this viremia will be more if you give the steroid. And if it is required when if the oxygen saturation is less or lung is involved, in such situation you can give the steroid. But if you want, you can give after 7 days. And in that also, it should not be more dose. What is happening? They are giving 125 milligram BD methyl prednisolone in such cases. So patients are, I think, getting the septicemia also, getting the mucormycosis also. So it should not be more than 60 BD and it should not be more than 5 to 7 days, max 10 days. And so it should be a short course. And I think if the steroid is used properly, judiciously, and all precautions are taken, definitely we can prevent the mucormycosis. Thank you.
Thank you so much, sir. These were very practical pointers, and we will have, even detailed panel discussion on mucor tomorrow. That is on the day 2. We are having a very detailed panel discussion on. Though it is not there a part of this discussion, but it has come in the question and answer session, and I request you to take up this question that for the initial stages when the vaccination started, the advice was to take it at an interval of 1 month. So there are many of our healthcare workers who have taken it at an interval of 1 month. So do we have any government guidelines regarding this, or are such guidelines in pipeline?
See, those who have taken the first dose, and if they have taken the covaxin, second dose they can take. And second dose, they can take up the covaxin. Covaxin is now in the June, it will be made available. If they have taken the Covishield, they can take Covishield in after the 84 days. Now, can they do the mix and match? Yes. Now, as the ICMR and Dr. Paul has already told us, if you have taken the covaxin and covaxin is not there, second dose you can take the Covishield. Or you have taken the Covishield and second dose you can take the covaxin. And I think that is a giving additive effect and not any side effects are happening.
Archana, if I can just add to
Yes,
what Sir said, and I think Dr. Suhas Prabhu will also agree with me. I think in the future it is going to be just like how it is in the Western countries. The flu shots they take every year. So maybe we also have to think in those terms also, because there is so much of mutation in this COVID. So I don't think we as health workers should be worried about this. Still there are papers who have to come out, because as you know, this is a new disease and it has just been about 1 year old. They do not know how long these antibodies will last. So once you get all these papers, only then we will come to know if we require to take another booster dose and when to take the booster dose. But till then, I think we should not be worrying as far as that is concerned. Those studies will come out. I think Dr. Prabhu will be able to tell us much more, because he deals with all these flu shots, especially in the pediatric age group.
No, I have really nothing more to add. Dr. Utture, you are right. We don't have the data, but I have a feeling, like you rightly said, that we might end up with having to give this corona vaccine every year, because the virus is mutating just like the influenza virus does. Thank you.
So that has been a really informative and wonderful panel discussion, and I think this has cleared out many of the doubts in the minds of our medical practitioners. And my heartfelt thanks to all the senior panelists who have given out time from the busy schedule to attend this panel discussion. Sir, if I may ask, what is the take-home message that each and every of you esteemed panelists will give to our medical practitioners? We have about 29,000 people who have logged in at one or the other time today. So what is your take-home message to our medical practitioners who are listening to you? We start with Lahane, sir.
The medical officers take home message first. I really appreciate and congratulate them that though they were knowing that they are going to get contracted, they are treating the patient. Secondly, I want, yes, we are the doctors and we can definitely face this situation. And I think we'll have to live with the new norms. And these new norms are there that the doctor is there to prevent your disease and treat you. So I salute your all the efforts you are doing and salute your devotion.
Thank you so much, sir. Taide, madam, is madam here?
No, I
I
think
think madam has been logged out for some reason. Yes. Dr. Prabhu, what would be your... Yes, Taide, madam.
Yeah.
Madam, what would be your take-home message to all the people who are attending this webinar today?
My take-home message will be again the COVID-appropriate behavior. We must insist, and I will request all the practitioners who are here that they must insist to their patient and wherever they are going, that they should stick up to the COVID-appropriate behavior. And that is what I would like to tell everyone, that yes, vaccine is there, the other things, treatment is there, but we are seeing the post-COVID complications are coming up. And the most important, we in future, I think we may have to face the mental health pandemic also. So I think facing all these complications is better to prevent than cure. Thank you.
Yes, thank you so much, madam. Thank you so much. Yes, Dr. Prabhu, sir, can we have a take-home message from you?
Yes, my take-home messages are pretty simple. They're based on what I said. First is, while we are not sure whether pediatric COVID will happen and to what level, think of COVID when you see a child with fever is my first statement. Second, learn to recognize the slightly different symptoms of COVID. I mentioned about MISC, and in my experience, MISC is much more common than actual COVID pneumonia in children. So the features are different. Learn to recognize that. Third point I want to say is triage. Majority of children can be managed at home. Learn to recognize which are the red flag signs. Instruct parents on how to look for them at home. And very important, LA parents' anxiety. They get so anxious. The mother says, my child has got COVID, and she starts panicking. We have to tell them that in majority of patients, nothing much has happened. I am there with you. You talk to me every day. Telemedicine should be done. As Dr. Utture said, we are allowed to do it. Learn how to do it effectively. And LA parents' anxiety, we can manage, and we will succeed in this third wave again in pediatric COVID. Thank you.
Thank you so much. Dr. Lele, can I have a message from you, sir?
Yeah, I think first and foremost, I would say that first opportunity, get everybody vaccinated, because just to tell you that almost 550 doctors we lost during the second wave time, and of course our team is analyzing that, and we found that many are not completed 2 doses of vaccination. So that little lethargy of vaccination has definitely been there in the doctors itself. So they should promote the vaccination. They should take themselves vaccination. And of course, as Dr. Babu said, not only in the kids, but in the adults, early diagnosis, and think everybody is COVID unless proved otherwise for first 5 to 6 days. And those are the very important days, because those time, the first in the family practice, we always see the first day, they always say, oh, this is just a little throat cold fever here and there. Just take the medicine, fever goes, they feel better. But then no, then we must see to it that on the 4th day or a 5th day or a 6th day, the symptoms or something changes. So that we must be able to find out. So that is what my advice to every physician is, that, you just be attentive and attend to that till one entire week. Don't leave the patient at all.
Thank you so much, sir. Coming to you, Utture, sir, as the president of Maharashtra Medical Council and as the host of today's webinar, so at the end of day one of this COVID summit, what would be your take-home message to the participants of this webinar?
Yeah, basically, what we have to understand is this is a war. And whenever there is a war, there is always an army and the weaponry. And today, let me tell you, we as medical faculty, and of course also our co-workers like the nursing staff and the ward boys and everything, we are the army and the weaponry, which is standing between this COVID and the general population. And because we are standing over there, let me tell you, as compared to all the Western countries, compared to the population that we have got, the number of patients who are getting infected, the number of deaths which are there is far, far less as compared to any other country anywhere in this world. So we have to understand this. Why I'm saying this is that many a times, you know, I get especially these young doctors saying, why we, why us? Especially, you know, when they feel that they have not been appreciated, that they have been working for this COVID for the last 1 year because of different reasons. Or, you know, you see these assaults that are happening over, all over Maharashtra and all over India happening also. But let me tell you, if we are not standing there at the border, things will become so bad that after that we will, you know, prevention, as we say, is better than cure. So if we cannot prevent this whole disease coming into the population, it's going to be very difficult for the whole population. And we are part and parcel, our families and our relatives and our friends are also part and parcel of this population. Having said that, another advice I would give you as being the president of a council, and as far as the ethical issue is concerned, for God's sake, do not say that I have got so much of experience in treating COVID. Your experience in treating COVID as an individual is almost zero, let me tell you. We are still struggling. Means when I say we, the experts are still struggling after treating thousands and lakhs of patients all over the world. I'm not talking only in India, but all over the world. They're still struggling to understand this disease. And as everybody says, that this is a predictable, unpredictable disease. So you can predict that it's going to be unpredictable in the future. And therefore, do not go on social media saying that this is the way to treat this disease. This is the way how I treat this disease, and my patients have never expired. My patients have never become bad. Because that is when the council has to step in, and the council has stepped in a couple of cases where people have given this false notion to the general public by going on to social media as far as this treatment is concerned. Stick to the protocols. If you stick to the protocols of what has been given by ICMR in India or by the Ministry of Health and Family Welfare, even if your patient succumbs and tomorrow there is a case against you, let me tell you, the council will be the first body which will protect you from all these things.
Yes.
So that is my only message before we end this session. Thank you.
Yes, thank you so much, everybody. Heartfelt thank you to all the panelists, to all the esteemed speakers, and to all the people who have watched this webinar till the end. To the last estimate that we saw, almost 29,000 people have logged in today for seeing this webinar. And as everybody rightly said, this is an evolving and a changing disease, and there is nothing definite that anybody can say that this disease is behaving in this way and it will continue to behave in this way. So if the disease changes, we will be having this webinar once again, and we will come back to you with more and more information. So we log off for today. Please do join us tomorrow sharp at 2 p.m. with the same webinar link. There will be no new link. You have to join using the same webinar link. Tomorrow we have very interesting topics lined up on COVID vaccination, panel discussion on fungal menace in COVID, pediatric COVID, long COVID, post-COVID complications, role of rehabilitation, and ethical issues in COVID. So see you all tomorrow, same time and same place. So thank you, everybody.
Thank you, everybody. Bye-bye.
So basically, Archana, to tell people, we have divided this into, as we had discussed, into two phases. Today's was what is there at present, with the last session, which talks about the third wave of future. And tomorrow, if you see, all the topics are basically going to be what is going to be the future problems as far as this COVID is concerned and how to tackle that. So tomorrow is also going to be a very important day. So I request everybody to log on tomorrow also, because you will be learning how to tackle this problem for the future as far as COVID is concerned. Thank you very much, everybody. And thank you all panelists. Thank you all MMC members. Thank you all doctors who have logged in today and made this a good success. Thank you.
Thank you. Thank you, everybody. Looking forward to a good
Thank you,
participation tomorrow.
thank you,
Thank you.
Utture sir, congratulations.
Thank you,
Archana,
Utture sir.
congratulations.
Thank you,
It
Lahane
was very
sir.
nice.
Archana ji, congratulations.
Thank you, sir.
Thank you.
Thank you.
Thank you.
Congratulations, everybody. Thank you.
Request to all MMC members, tomorrow again, half an hour before we will log in, all of us, before the
Yes.
session starts at 2 o'clock.
Yes, yes.
Thank you very much.
Thank you, sir.
Okay, bye-bye. Archana, wonderful job.
Deepen, you can stop recording, please.
Sir. Yes.
सर लाईव्ह पण काढू.